We'll roll call in about a minute. Stand by.
Good morning. Just before we get into roll call, could the person who's called in, whose last two digits begin in 11, could you please identify yourself?
Hi, Sarah. It's Jim Talbot.
Thank you very much. Are you able to mute your microphone? Is that possible?
Madam Clerk, are we good to go?
We're good to go, and we're going to activate a vote just to have a wee test before
Sure.
we get started.
Make sure you're in the special City Council meeting for December 8th, which I will call to order and begin by recognizing the traditional land on which we're gathering today, which is Treaty 6 territory, territory of the Cree, the Dene, the Saulteaux, the Blackfoot, and the Nakota Sioux peoples, as well as one of the great homelands of the Métis Nation. And I was reflecting a little bit on the time when the treaty was signed was a time of disease, a time of poverty, a time of great uncertainty in these parts. And the treaty was an instrument of public health, an instrument of security, an instrument of co-prosperity. At least that was the promise. We're still all working to deliver on that. But I was reflecting on that this morning and hope we can be guided by some of that spirit of working together to overcome very difficult circumstances our community finds itself in right now. We're not alone in those circumstances, but here we are. I'll roll call and then provide a few more comments from the chair to explain the agenda in a moment. So I'll start this time with Councillor Katarina.
Good morning.
Morning. Councillor Zadig.
Good morning.
Thank you. Councillor Essinger.
Good morning.
Thank you. Councillor Hamilton.
Good morning.
Thank you. Councillor Henderson.
Morning.
Thank you. Councillor Knack.
Good morning.
Thank you. Councillor McKean.
Good morning.
Thank you. Councillor Nicol is here in person.
Good morning.
Morning. Councillor Paquette.
Good morning.
Good morning. And Councillor Walters.
Good morning.
Morning. Councillor Banga. Let me know he might be a couple minutes late. He will be joining us. And Councillor Cartmel.
Good morning.
Thank you. Okay, that's everyone. You can vote yes just to register the vote if you want and see if they're, how the system's working this morning.
We've got all but one, but we'll check them in and we'll get started.
Okay.
Thank you.
All right, so just on the adoption of the agenda, which I'll ask for a motion in a moment, but the purpose of today's meeting, which I called on short notice, and I appreciate everyone making themselves available under these extraordinary circumstances. Clearly, this is our top priority of business, along with budget and the other issues we're dealing with this week. So there are three reasons for today's meeting. The first is to receive some information from administration, which will come in two parts. The first is sort of the general COVID update that we would get at an EAC, but the second part will be an answer to questions raised at the last EAC about tools available to us under the Municipal Government Act outside of emergency powers to enact stronger measures. And because they're not emergency powers, they needed to come back to a council meeting. So you'll get a light EAC-like briefing at the beginning. Then we'll have an answer to those questions about MGA powers, which are limited, but there are some options there for us to consider. And I thought it was timely to bring those back to council during this time block rather than tacked onto one of the other meetings, which are already overburdened this week. So we'll get that information from administration and have the option to set some things in motion. The other part of our agenda today, the second matter, will be advice on public health measures for COVID-19. We had a request from the Edmonton Zone Doctors Association to present, and the co-chair of their COVID-19 response committee happens to be Dr. James Talbot, former Chief Medical Officer of Health, and I thought that that would be, after a conversation with him and other members of the committee last week, I thought council would benefit from the opportunity to hear some information and ask some questions of folks with some familiarity with what's happening here. And that discussion could be public for the benefit of the public's information as well. And then finally, once we've received all of that information, I do think there are a number of intergovernmental questions for us from an advocacy perspective. Obviously, request for stronger measures. I've been calling for that, but would invite council to make a resolution in that respect. And then also for us to ask for some clarity from the province and perhaps some delegated authorities through the city charter to make some actions with greater certainty and to clarify our ability to provide measures that would lead to federal aid for businesses impacted by such measures, which is still unfortunately ambiguous at this point, but we'll get more into that today. So that is the proposed flow of the agenda before you. Councillor Essinger, if you would be so kind as to move the adoption of the agenda.
So moved.
Thank you. Seconder?
Second.
Thank you, Councillor McKean. Any questions on the agenda? Not hearing any, please vote.
Good to go, Mr. Mayor.
Thank you. Display the vote. Carried. And we have no protocol items today. I'm going to just suggest that we select all of these items because they're all verbal. They all must be selected. We have no additional requests to speak or time specific. We'll tackle them in this order. Hopefully we'll finish with them, but if we need to overflow the either the 5.3 or the 5.4 discussion, we have options if necessary, but hopefully we can get through this morning. That's up to us. So, Mr. Laughlin, appreciate that your team has been looking very closely at the continuing situation and appreciate your update on the COVID-19 situation from city administration's perspective.
Thank you, Mr. Mayor, members of council. This is the first component here is a really short update. It's just really an articulation of the latest numbers. And then as the mayor said on 5.3, we'd be able to provide more information related to additional restrictions that could be considered. Joining me in chambers today, as regularly she does, Bonnie Andreychuk, our city solicitor, and our new chair of the COVID task team, Jennifer Cluth. I messaged council that David Aiken has returned to his home position, so just introduction to Jennifer Cluth, who is the new chair of the COVID task team. Also, members of the executive leadership team are joining us remotely as well, should the questions extend to that group. So, throughout the pandemic, we've been frequently asking ourselves if there is more that we can do to protect the health and safety of Edmontonians. Our goal of exiting the pandemic with our employees, residents, and economy in a strong, healthy state depends on taking appropriate risk and action. The grim COVID-19 data for Edmonton Health Region is alarming and unacceptable. The virus is in a dangerous, exponential growth phase in our community. Based on the growing concern this morning, we would like to share with Council information and advice to assist in your assessment of the situation. We will provide the latest public health data which paints a clear picture of the serious situation we face. And again, for Council's consideration, share information about the legislative approaches available for battling this local crisis. So as I said, this is a short presentation, and this is essentially the information we wanted to provide the latest data on. It's been 11 days since the state of public health emergency was declared and the new provincial restrictions were introduced. As the data shows, the spread of the virus has not let up. In fact, the Edmonton Health Zone continues to break public health milestones, which we know will lead to significant strain on our health system in the coming days. With the growing infection rates, hospitalizations, and ICU admissions in the community, additional restrictions are required. The data trends are alarming. It is clear that we cannot wait for the expected course correction to happen. We must be prepared to adopt more significant restrictions that will quickly break the chain of transmission. Edmontonians have trusted us to serve their interest, and that includes protecting their safety. And again, later in the presentation, I will talk about some of the measures that City Council could consider. I will just stop there to allow you to take in the data, and that's the end of the presentation in terms of an update, and prepared for questions now or when we move to item 5.3.
So my suggestion would be that we also get the presentation on 5.2 and then cross-reference questions on both, and then move into 5.3 on tools and measures in response to the COVID situation. So unless anyone has a burning question for administration now, I think most of the questions will probably make sense after 5.2 and then in the context of the measures discussion under 5.3. So, okay, so.
Don, just one. Sorry.
Sure.
It's Michael.
Go ahead.
I didn't take that in fast enough, clearly. There was a statistic that talked about the ratio of cases to Edmontonians, and I don't know if that was on there. So like 1 in 250 Edmontonians had, I think I saw that in a news report recently.
We didn't have that on the slide. Councillor Walters, I'll look to Jen to see if she has that information available.
Our active case rate is 727.8 per 100,000 in the community.
728 per 100,000, okay.
Yes.
Thanks, that's what I just want to clarify. Thank you.
Thank you. Councillor Henderson.
Yeah, just a quick question on the breakdown of the outbreak locations. If we have that, are they fairly consistent, or what's actually in that number?
Again, I'll see if Jen can provide some of that information.
I can comment on those areas which have the highest, or regions that have the highest outbreaks, if that's helpful.
Well, I just wondered if there was a pattern to them. That's all. If there's if there's something that's in there, But if we can get that later, if it's not easily readily available, that's fine. or whether or not the kind of locations were shifting.
I can,
We
I can-
we can assess that and
Okay.
prepare for answering that question as part of
Perfect.
5.3.
Thanks.
Thank you. Looks like we can reserve all the other questions for admin for later. Thanks for that. So for 5.2, to introduce the Strategic COVID-19 Pandemic Committee of the Edmonton Zone Medical Staff Association recently reached out to meet with City Council, and as a result, we've invited them to present here today. Our speakers, who are joining us both in person and virtually, will be the first to tell us that they're here to speak objectively as practicing medical healthcare providers, and that they are politically agnostic. And this was part of the understanding of having them here. The Medical Staff Association speaks for and includes, among others, 1,700 physician practitioners, medical staff who practice in a variety of settings, community-based specialists, and clinical scientists. And I'll now introduce the delegation that's with us today. Here in person is Dr. Noel Gibney, Professor Emeritus at the University of Alberta's Department of Critical Care Medicine. He is the former Zone Clinical Department Head of Adult Critical Care, Edmonton Zone, and currently co-chairs the Edmonton Zone Medical Staff Association's Strategic COVID-19 Pandemic Committee. Welcome, Dr. Gibney. Joining us virtually is Dr. James Talbot, who is Alberta and Nunavut's former Chief Medical Officer of Health and Adjunct Professor at the University of Alberta's School of Public Health, and he currently co-chairs the Edmonton Zone Medical Staff Association's Strategic COVID-19 Pandemic Committee. Also joining us online is Dr. Nija Bakshi, who is an internal medicine physician practicing at the Royal Alexandra Hospital for the last decade, performs outpatient work in Sherwood Park's Integrative Health, and she has worked closely with the Royal Alex Hospital team to develop and execute its COVID-19 unit since April. Dr. Lenora Saxinger is here in person as a resource for our presenters. She's an infectious disease specialist whose work is focused on antimicrobial stewardship and resistance and improving surveillance. Her work includes education, policy development, and knowledge translation for public and healthcare professionals. That will be super handy today for us. Thank you. And last but not least is Ms. Bobby Jo Hawks, manager for the Edmonton Zone Medical Staff Association, who comes armed with a master's in health administration, supports the team's policy issues management and communications. So Drs. Gibney and Talbot will open the presentation, followed by Dr. Bakshi. Over to you, Dr. Gibney. The floor is yours. Oh, make sure your microphone's on, sir.
Thank you very much, Mr. Mayor. With me in this presentation, a co-presenter is going to be Dr. Jim Talbot, and afterwards questions can be answered both by Dr. Saxinger and Dr. Bakshi. I'd like to thank Mayor Iverson for this opportunity to address the City Council. I'd also like to thank our healthcare professionals in the province for their heroic work in caring for patients with COVID-19 and all the other patients who still need care during the pandemic. I'd like to thank Alberta Health Services leadership for their work in contingency and disaster planning in the current situation. And I'd also like to thank Dr. Dina Hinshaw and her team for their tireless work in monitoring the pandemic, informing the public, and providing professional advice to the government of Alberta. I made a personal decision to become involved in this, having had experience during the disaster that occurred in Haiti in 2009 with the earthquake there, where I saw exactly what happens when a disaster affects a community to the extent that the medical system is overwhelmed. I became concerned as the numbers from this pandemic grew, and thus my involvement. The current situation, we've heard some of it. This is December 5th information, and we can see that on December 5th, 612 new cases at 33% of the Alberta total. Tests over 8,000, 35% of the Alberta total. Positive tests, I think typically at that time it was about 10% in Edmonton, 12 deaths on that day. In hospital, 337 in Edmonton, up 37 from the previous day. And in ICU, 59, and Edmonton has had a total of 250 deaths, 41% of the provincial total. Yesterday, we had 1,725 new cases, and Edmonton has 20,000, or the province has 20,000 cases. 8.5% of tests in the province were positive. 609 people in the province in hospital, and 108 now in the intensive care units, with 16 deaths in the previous 24 hours, for a total provincial death toll of 631 people. Dr. Talbot will take over from this point.
So I'm hoping everybody can hear me. I have a crappy internet connection, so I'm looking both phone and the internet.
Yeah, we can hear you okay, Dr. Talbot. Thank you. Go ahead.
Great, thank you. So this slide shows the active cases per day. Noel gave you a snapshot of where we were, which was concerning enough, but the trends are also equally, if not more concerning. Green is Alberta. You can see that in the beginning, because of the early and effective action that was taken, the rate of increase was significantly lower than a lot of other provinces. This has been normalized, so it's per capita per 100,000. And then we enjoyed a pretty good summer and early fall with things staying relatively flat. And then in the last 6 weeks or so, we've seen this more rapid growth, which is now at an exponential curve, doubling about every 2 weeks. The Canadian average is in red, so we started off significantly below the Canadian average. Now we're significantly higher, and at the rate we're going, we're likely to overtake Quebec. If I could have the next slide, please. This just reinforces, you take a look at the weekly cases per 100,000, that this is a lead that we don't particularly want in Alberta. Next slide. This is the test per capita by province. This is really to reinforce a point, which is that testing has never, I speak as a lab physician, testing by itself is never enough. It's the actions that are taken as a consequence of the testing that's important, the contact tracing, and the decisions that are made about what to open and what to close. The problem with the surge that we're seeing now is that testing and the contact tracing that we rely on are becoming overwhelmed. So we need something to reduce the number of cases so those things can return to being effective again. Next slide. This is a positivity by health zone in Alberta. Here, Edmonton is in yellow, and unfortunately, our test positivity, the number of tests positive per person tested, has been increasing. We're now in the 10% range, with a range that the WHO considers anything above 5 means that you really have to do something different, because your ability to test, contact trace, and isolate and quarantine, which is all part of a targeted approach, suddenly is in danger. And you have to consider moving to more drastic lockdown kind of scenarios. Next slide. These are the active COVID-19 cases per day per 100,000 people for the zones. The thing that I want to highlight here is that Edmonton requires special care because it's in special circumstances in terms of its contribution to what's happening in Alberta. But that 4 of the 5 zones are showing increases. This is up to date to the 5th. And so the latest measures to try to bring things under control are clearly not working to bend the curve in most of the province. And one of the concerns with that is that Edmonton, along with Calgary, provide specialized services, particularly in tertiary care hospitals, that the other zones depend on. So it's not just the people of Edmonton that need to be concerned about the effect it might have on acute care. It's also the kinds of things that the north and central zone depend on Edmonton for. So the next slide, as we look at what's happening in the zone, I'll hand it back to Noel, because he's much more aware of that than I am.
Thank you, Jim. This slide shows the rate of increase in hospitalized cases between April and December, and you can see that through April and the summer, the numbers were actually very, very low. And then starting in October, the numbers have progressively gone up. And you can see that in the last 3-4 weeks, the numbers have gone up exponentially at an extremely rapid rate and are now virtually heading up straight. This is the ICU admissions in the Edmonton zone. And again, paralleling the hospital admissions, you can see that beginning in November, the rates have increased and again have rapidly increased in the last 3 weeks. In keeping with that, we can see that over the last month, the cumulative death rate has increased very significantly and very rapidly. And typically what we see is that with respect to the hospitalized cases, patients are in hospital typically for about a week before they need to go to ICU. And then in ICU, the average length of stay is approximately 2 weeks, with death occurring usually around the 10-day mark. This slide looks at the deaths by date. And again, you can see there was a spike in April and May, which then tailed off through the summer. Some increase again in August, controlled very nicely. And then over the last 6 weeks, we can see that, again, the numbers have progressively increased and are continuing to increase on a daily basis. This slide looks at the relationship between hospitalizations and ICU cases between March and December 2020. And the important thing here is to note that without a meaningful change in the rate of infections, hospitalization, and ICU admissions, it is likely that there will be over 1,000 hospital COVID patients and 170 ICU COVID patients by December 17th. And again, if we don't do something beyond that stage, over 2,000 COVID patients and approximately 300 ICU COVID patients by December 31st. This leads us then to what are the consequences of continued increase in new cases and lack of effective measures being implemented. We're already seeing that the hospitals and continuing care centres are becoming progressively overwhelmed. The healthcare professionals are working at maximum capacity. There's need for help staffing the continuing care centres. There's been cancellation of booked surgical cases, and that's likely to increase and significantly increase. The non-COVID patients that normally come to the hospital are still needing care. Those are the strokes, traumas, pneumonias, etc. The hospital staff are already exhausted, many sick, others in isolation or quarantining. And it's becoming an increasing challenge to maintain the quality of care. As we start to double bunk in ICU, there's an increased risk of COVID transmission in overcrowded spaces. And it seems that we may end up with field hospitals at the U of A Butterdome and Saville Centre in order to care for the lesser sick patients, to allow the sicker ones into the main hospitals. At the same time, our ICUs are overwhelmed. We're surging into new ICU beds without ICU-trained professionals who've had a very short orientation to ICU. It's becoming an increasing challenge to maintain quality of care, and I've heard stories from nurses at the challenges that they face in these situations. We risk having an inability to provide life support to everyone presenting in distress. We risk having a rapidly increasing mortality rate. And we risk having to implement a triage protocol because of limited resources to provide care to those most likely to benefit. We know what happened in Italy back in March, where Italian doctors had to make decisions as to which patients they would actually provide life support for because of a limitation in ventilators and ICU spaces. We know, for example, that Ontario published their clinical triage protocol for major surge in the COVID pandemic in March 2020. That's available publicly. I'm also aware that there's a similar document currently with the Alberta government which hasn't been published and hasn't been provided to the critical care professionals as yet. And also, we know that last week, a man in Pennsylvania went on Facebook to help find an ICU bed for his COVID-stricken mother. We risk being in that situation. Dr. Talbot?
Thanks. Well, I just want to emphasize a couple of things that Noel said. One is that because 4 out of 5 zones are surging, Alberta Health Services, which has been absolutely brilliant at being able to shift resources to where the most need is really handicapped in its ability to do that, because within the province, we're all experiencing surge at the same time. And I also want to make clear, triage is a word that has kind of crept into the English language, and it seems to have sort of an innocuous meaning to people. But in the sense that Noel was meaning it, and the Ontario document and the Alberta document to me mean it, it goes back to its literal meaning. It's the people who will recover without assistance, the people who are likely to die even if they get assistance, and the middle ground in between in which assistance might make some kind of difference. And so it's a means to restrict to only those in which there's a reasonable chance of being able to make a difference. And if you had full resources, you would be expanding it beyond that group, and you would be having success beyond that group. So it's literally about a guide for how to make life or death decisions. So I'm on the evidence slide. There are only 2 choices in this pandemic: either the virus is in control or we're in control. I think it's clear from the data we've shown that the virus is in control. So that means right now the virus is violating Albertans and Edmontonians' right to be safe, to be healthy, and it means that it's restricting their freedom of movement. There are a lot of grandparents who are purposely restricting their movements so they can't see children. So we already have a crisis in terms of civil liberties, and it's brought to us courtesy of the virus. Public health restrictions can bring down the number of people who are infected and dead, and they allow us to make the decisions about how much damage is going to be done to society and how much is going to be done to businesses and the economy. If we don't have control, then the virus gets to decide those things, and that's where we are right now. So we know there are harms that are potentially part of our response, but if we're in control, we can try to minimize those. And we do want to minimize people delaying seeking health care. There are primary care physicians all across the Edmonton zone who are eager to help people with whatever problems that they're having, giving them advice, seeing them in a safe way. And if you have a problem that's more serious than that, they can help make you make the decision about when to present in emergency departments. And I'd like to make it clear that Alberta Health Services and its dedicated people are still able to serve people in the emerge department. So we don't want to frighten people away right now. We're painting the picture of where we could be 2 weeks from now. If we continue to delay, when I started sounding the warning on this on the 15th of November, I said that it was going to double. If we had taken effective measures there, we could have been bending the curve by now. It's going to double again by the middle of this month, and if nothing effective is put in place, it will double again by the end of the year. So that's 2 times, 4 times, and 8 times the cost of what it would have been to bend the curve 2 weeks ago. And that peak will take longer to bring down. There is some lack of clarity on what the recent surge is due to, and that's why a more effective lockdown approach rather than a targeted approach, what we're aiming for. The next slide. So the recent research all across the world is that there are super spreader points of interest tend to be in indoor areas in which people are not able to social distance or refuse to social distance and or don't wear masks. So it's very clear that you can end up with problems in fitness centers, cafes, religious organizations, physicians' offices that haven't taken proper precautions, and full-service restaurants accounting for many of the points of interest in these studies. Next slide. This is just some data that's been taken from cell phone proximity around various hotspots in the U.S., showing the kind of contribution any kind of indoor center where people congregate can represent to spread. Next slide. One of the comments that we sometimes face is that, healthy people are often not showing up in the hospitals, but there's still a concern about what happens to people who don't end up in the hospital and end up with very, very nasty long-term symptoms. And they also represent an ongoing drain on the healthcare system. So why have the current measures not been effective enough? The evidence supports swift and early action, which is what we did in the spring and which we're not doing now. Contact tracing, as I mentioned, has been overwhelmed, so isolation and quarantine efforts are compromised. So for instance, if you decided to keep your restaurant open and contact tracing doesn't get to you for, say, 7 days after one of your employees is tested positive, you've had 7 days of transmission from that employee to other employees and to their staff and to their customers. And so that's another reason why we think a different strategy is required. And there may be less public attention. It's absolutely clear that cold weather is not our friend driving people indoors. There's mixed messaging still going on about the effectiveness of masks. I know that City Council is aware of that. And the lack of enforcement, we still don't have province-wide approach to masking. And then misinformation spreading about the seriousness of the COVID has been really hard to deal with. Ordinarily in Alberta, between 30 and 100 people die of influenza. We're already at over 560, and we've had that many deaths with the lockdown. So anybody who says it's just an ordinary flu is trying to get you to make a bad decision. Next slide. So how do we bend the curve? We need to minimize closing door contacts. Eventually, we need to get the transmission below 0.8 and new cases under 300 a day. Kinds of places where they're most at risk for that kind of transmission: casinos, bars, in-restaurant dining, gyms and sports centers, faith assemblies. And then we need strict enforcement of limited numbers and masking in indoor spaces in larger stores and shopping malls. There's two methods of control on shopping malls, one outside the mall and then with the individual stores, and encourage as many people as we can to work from home. I'd like to make clear we said we were agnostic. What we mean by that is that if the provincial government comes up with effective measures, that's great with us. We're happy. It means the stress comes off the system and our colleagues will be able to relax. That would be great. We also are very supportive of the places where the worst increases are happening. For instance, at Edmonton, for the people who are locally responsible for their health, for the health of people, to make exactly the same kind of smart decisions. And finally, we want individuals and families to reduce their own risk by taking the advice that they've been given. We would like business owners to think very hard about the way they can maximally protect their employees and their customers. Similarly, faith-based leaders with their congregants. The more people join the effort to bend the curve, the quicker we'll do. And this is the last slide. Just want to emphasize that we've done really well. If we were in as bad a state as the U.S., we would have 6 times as many people dead. So everybody, Alberta Health Services, Alberta Health, City Council, individuals, the people who lost their businesses, the people who lost employment, the people who didn't get to go to their wedding or didn't get to go to see their grandparents when they were dying. Everybody has sacrificed in this province and at the Edmonton zone. Everybody has the right to feel like they've done well. But we're all tired, and we get that. But we've seen this play before. You know, if you're an Oilers fan or a Raptors fan, it's the last period. We're protecting a lead. The virus is that close. It means that, the vaccine is that close. It means that everybody we lose now that we don't have to is going to be a tragedy. So we do what we do in the last period when we're protecting a lead. We clamp down and play the hardest defense we can, and we play every shift as if our lives depend on it, because they actually do. Thank you.
Well, thank you very much for that very clear presentation. I think that's helpful to us and to the public to hear. I'm sure there are questions from my colleagues here. The speakers list is open.
I'm sorry, Mayor. Were we going to have Nija talk a little bit about her personal experience?
I apologize,
or did
yes.
I take too long?
There's one more element to the presentation. We'll open the speakers list to start to populate it now, but Dr. Bakshi, go ahead.
Thank you very much, Mayor Epson and council members, for allowing us to speak. As mentioned in my introduction, I'm an internal medicine physician at the Royal Alexandra Hospital, and have been working closely with our operation teams and other physician leads to develop our COVID unit since the end of March. And we have developed a process and protocol as we've learned about the types of patients that we are seeing, and had a bit of time over the summer to perfect that when the numbers were low, as indicated by Dr. Talbot and Dr. Gibney with the first lockdown. And as we have now headed into November and now in December, we are seeing extreme exponential rises of cases in hospital, which is certainly overwhelming healthcare workers. Personally, I have worked on the COVID unit now 8 weeks in the last few months. Most recently, I've worked 4 weeks in the last 2 months, and just came off service yesterday on what was probably the hardest service week that I've ever done in my life. We are seeing increasing number of patients coming in who are very, very sick. And for physicians, I think the most challenging thing that we have noticed is that we cannot predict who is going to deteriorate and when they're going to deteriorate. We are often seeing patients get sick 7 to 10 days after they swab, and sometimes they're doing well on the ward for a day or two, and we're planning for discharge, and 3 minutes later, we're calling ICU with a crash cart. The strain that this is putting on not only physicians and nurses, respiratory therapists, as well as environmental care workers who are helping us to keep these rooms clean and turning them over so we can bring in the next patient is visible. When you look at people's faces walking through the hallways of the hospital, we are tired, we are demoralized, we are unsure how long we're going to keep up with this. But we also know that we went into healthcare for a reason, and that we're going to continue to try to provide quality care for every single patient that comes through that door. We are working around the clock to ensure that we've got enough physicians, nurses, respiratory therapists to serve these patients. But as mentioned, if nothing changes in terms of restrictions, we are getting very close to overwhelming our workforce as well. We also have the added cognitive load of caring for complex patients. This is not just the flu. These patients go into respiratory failure quickly. Our traditional strategies for the flu don't work with COVID. We are trying strategies that we typically use in ICU called proning. We're using that on the ward, where we're flipping patients over onto their belly to try to help them to breathe. These are things that we were not trained in, but we're adapting as we go along. We are all working collaboratively to make sure that staff going into these rooms are protected, that even if a patient needs our assistance, we're ensuring everybody has the appropriate PPE on, so that when we go in, we are all protected so that we're not transmitting. All of that is physical, emotional toll that we're taking on, and it is certainly something that we are seeing on and on. And I think one of the other things that is important to realize is as healthcare workers, we're also Edmontonians. So we are also bearing the societal responsibility that every one of us at this meeting is bearing, that we want to protect our fellow Edmontonians. We want to make sure we're not bringing the virus to the community. We're all going home to our families. We're all having a decontamination area so that we're not bringing things home to our family. We're ensuring that our families and children are staying safe. But we're taking that stress with us when we go to work every single day. My hope is that we continue to work together as a community to slow the spread, to make sure that we have the capacity in the hospital, not only for our COVID patients, but as was alluded to, our non-COVID patients as well. We need to be able to provide equal quality care for everybody. Thank you.
Well, thank you, Dr. Bakshi, and to you and through you to your colleagues for your efforts under these tragic circumstances. Please convey our thanks on behalf of the people of Edmonton. So I think that's the full presentation now. The delegation's on hand to answer questions here. Councillor Henderson?
Yeah, one of the things I've been wondering about, and if there's any work being done on this, is more around the behavioral side, because it strikes me that we had the level of compliance we had in the spring when people's risk tolerance was different than it is right now, was part of what made it easier for us to deal with this in the spring, and that people's idea of what risks they're prepared to take personally, I suspect, has shifted and changed. I think part of the problem is that the risks they take are not personal risks, they're societal risks. But that's something that I think has been really hard to get through to people. So I'm wondering from that, in terms of choices and things we can do, if there's been any work done, or if we've been able to see from what's happened in other parts of the world, if there are a set of choices that we can make that can deal with, that COVID fatigue. It just seems like the public's in a different place right now in terms of their willingness than they were in March, and that's going to be part of the impediment that we have to deal with. So is there any work being done around that question, that kind of behavioral question?
So I'll take a crack at that. In public health, we study the things that work and we study the things that don't work. And we have kind of one of the world's worst case studies to the south of us.
Yeah.
And so one of the things that we now know, both from seeing it work and seeing it fail, is that if you have strong leadership throughout the entire, I'm going to restrict myself to province, but I'm drawing from other countries' experiences and other places' experiences. If you have strong, consistent messaging throughout that masking is important, that people really have to exercise the best choices that they can to see as few people as possible, you get more of an effect. In the beginning, when we faced this, we had that. All you had to do was to take a look at the traffic on the streets, and you knew that everybody was paying attention to that messaging. Right? And on this one, the messaging has not been as consistent as it could be. And so the secret then is to make sure that we're absolutely consistent. And I'll give you an example that I've heard probably a dozen times from friends, neighbors, relatives in Alberta. Is you're saying that reducing the number of contacts is important, and you're telling me that I shouldn't see my grandparents or my grandkids at Christmas. But I can walk into a bar or a restaurant and be with complete strangers. So how does that make any sense? So that's the second thing. The messaging has to make sense to people. If it doesn't, then we start to disregard it. The messaging has to be fair. Everybody is in this together. Everybody needs to make sacrifices. We should not be picking winners and losers amongst the various groups. And so, I can't really, that was a great question. It was really broad ranging, and I can't really do justice to it and let other people. But Noel, I don't know if you want to say anything about this or.
Lenore, Laura Saxon here. I actually have a comment about that. I'm aware that there is some provincial and actually national work right now looking at aspects of behavior change and messaging to the public. So there are efforts underway to try to tackle that very large problem. I guess one of the challenges is that as a consequence of the, I guess, variability of people's behavior change, we're in a bit of a crisis situation. And so it seems like, at least some people think that we've hit the ceiling of how much we can rely on, willing personal responsibility unless there's a significant change in some way. And I think the timeline in which you could affect a significant behavioral change by figuring out the best messaging is not really a realistic thing to prioritize right now versus trying to get control of things and optimize the messaging for the phase of when you want to come away from restrictions, when you've got the lid on things and it's simmered down. So there's also a question of prioritization. I would say, though, that there definitely is work going on right now trying to tackle some of those questions. And there's also a lot of work going on to try to tackle some of the misinformation that I think has led to some of the variability in behavior. So those are in progress, but I don't know if they're a proximal goal right now compared to getting control of the situation again.
Thank you. Next up is Councillor Paquette.
Thank you, Mr. Mayor, and thank you for coming out to share your expertise and experience with us. It's deeply troubling. So my question, first question, obviously people are experiencing restriction fatigue because this is stretched out for so very long. And it seems to me, and I would like your opinion, it seems to me that any restrictions that stretch this out for another 4 months, 6 months, a year, may not be effective as people just stop listening. Or, as was stated, the restrictions just don't make sense. So, there's also an economic component to this. We're talking about the COVID fatalities and COVID impacts, but there are also economic impacts. There's mental health impacts. There's an enormous range of negative results out of the path that we've been on so far, especially when compared to the path that other jurisdictions have taken in order to end the need for onerous restrictions month after month after month, coming up on a year. So I'm just wondering, in the best of all worlds, if we could just not try to manage spikes after spikes after spikes, and not try to manage this restriction fatigue over long periods of time, and we could just get rid of the problem, what would you like to see?
Noel, do you want to tell the story of Ireland first before I deal with the specifics of the councillor's question?
Yeah, absolutely, Jim. If I could just comment to the council, my son is living in Ireland, and they've had significant outbreaks as well. And what they've done is they've had a series of short lockdowns. You could call them circuit breakers. And they know exactly when these are going to end, providing the end points are met. And in fact, they've just gone through a 3-week circuit breaker. And as of 2 days ago, everything opened up. They're ready to have Christmas. The bars, the restaurants are open. But there's also an expectation and an understanding that as that happens, they're going to see a resurgence of COVID. And so probably the week after Christmas, they're expecting probably another circuit breaker of 2 to 3 weeks. The length of time would depend on the degree of community spread at the time that would be introduced. And I think what has been learned is that sequential circuit breakers followed by openings seems to be more effective than just dragging out everything forever in a half measure. The half measures don't work because people are tired of them, but if they have something to look forward to, they seem to comply better.
So the only thing I'd add to that is that I understand that fatigue. I mean, we're all feeling it, and it's hard, but we're so close now. I mean, we're going to be getting an effective vaccine, granted, starting in smaller numbers, apparently by the end of the month. And within the first 3 months, there'll be more vaccine available, and we'll be able to protect those most at risk and those who are doing the most to protect other people, or healthcare workers and the vulnerable. So as opposed to back in March, when we didn't know if there was going to be a vaccine, we didn't know if it was going to be effective, we had no idea how long this was going to last. We're now in the stage where we can see, the sun coming over the horizon. And that's another thing I think we need to add into the idea of these circuit breakers, is that there wouldn't have to be very many of them. If we get one in place now, bring the curve down, then, how many more of those are we going to need between now and when vaccine is more widely available?
Yeah, thank you for that. I think about the drain on budgets of governments across Canada, and we're bleeding money, and it would be great if it could just stop. I'm wondering, do you think that with the advent of the vaccine, are folks going to get overconfident, and then our restrictions will fail again?
Yeah, that's a real concern, and that's why we're trying to emphasize that it would be a tragedy to lose anybody. It's like being the last person to die in the Second World War. We just don't want anybody not to make it to that finish line who could have made it if we continued to behave responsibly as individuals, as businesses, as governments.
If I make a comment as well, it's Dr. Saxinger. I would just say that I think there's arisen a bit of a notion that public health, people in public health or in medicine are not aware of the economic impact of lockdowns, when in fact, I think that everyone who's paying attention to all of the determinants of health are very much aware that lockdowns offer a lot of risk, both within the healthcare system and not being able to do what we'd like to do, and also to the communities and individuals whose financial health and food security and businesses whose future are affected by restrictions. Those are all issues that affect health as well. But I also would point out that there's a fairly significant body of literature from economists, some of the ones that I've been following from University of Calgary, for example, that would suggest it's not your money or your life. It's actually better to control the pandemic in terms of economic health than it is to, basically try to ineffectively not control the pandemic and keep things open, because people vote with their feet. And even though things are theoretically open right now, a lot of restaurants are seeing very few people coming, not enough to actually pay their bills, because they're afraid of uncontrolled transmission. And so there is, I think, a good argument to be made that rapid, effective pandemic control allows more robust economic recovery in the face of it. And so I don't want to, forget to point out that false dichotomy, because I think that that's something that really has to be weighed carefully, especially when you're looking at planning for an entire city.
I hear you loud and clear. Thank you.
Thank you. Councillor Knack is next. Go ahead.
Thank you, Mr. Mayor, and thank you so much for your presentation. This is that wake-up call that I think we all need to sort of remind ourselves what we need to be doing right now. So I just can't thank you enough for sharing that, and I wish that entire half hour could just be every 6 o'clock newscast, and they would just play that half an hour and that's it, so that people could understand what we're tackling right now. So a few questions. There's been a lot of conversation, it was even referenced in the presentation, around this R value, and there are, as noted, you have access to that information, although it's not being shared by Alberta Health Services regularly. Is it broken down by zone? So do we know what Edmonton zone's R value might be compared to the rest of the province?
Lenora, do you want to take a crack at that as our resident expert?
Sure. So the R values are available by zone, and there's different ways of calculating them. So I don't have access to the or regular access to the official public health R values, but they can be calculated outside. They have tended to be in the 1.2 to 1.4 range, more recently trending below 1.2 to 1.1, which would suggest that some of the measures that have been put in place probably have made some impact, and that, in fact, I have to acknowledge lots of people are doing, the best they can and good things to reduce spread. It just really does look like the current targeted interventions are not sufficient to control spread. The problem with the R value, of course, is that you can't just look at a target of less than 1. So that would mean that on average, one current case will cause one more case if the R value is 1. If it's below 1, one case will cause less than one case. And so over successive, generations of spread, you see a gradual decline. If the R is sitting at, 0.9 even, which is, below 1, which is a stated goal, you will still see, if you're seeing, 1,000 cases daily, the next day you see, 900 cases, and so on and so on. So you're actually having a very low decrease, which in the face of very high case numbers is not enough to actually prevent in 2 to 4 weeks, we see hospitalizations and ICU numbers continue to rise. So there is a lag time of the effect. And the R number should always be looked at in the context, actually, of the overall case numbers as well, when you look at the volume of what we expect to see affecting the population and our healthcare system.
So based on where we're trending, we don't want to just, really to offset this most recent spike, we need to be at like a 0.8 or a 0.7 for the next little while to get out in front of this. Is that at a high, I don't know what the right number would be, but you need it substantially below 1 to bend that curve. Is that correct?
I would support your math on that, yes. So the quicker and more decisive a drop in R, you can actually see a depressing continued increase in cases for a short time after interventions, just because they're already baking, if that makes sense. But you see the R start to drop quite quickly. The trend should be good, and then you see the cases start to drop after. And more decisive would result in a larger effect.
Okay.
If I could add one more thing to that. Lenora talked about in the face of really large number of cases. This is part of the problem with the whole calculation about indoors and what kind of precautions you need in place. Because the precautions that you have in place, if you have 100 people and on average one is infected, are not necessarily going to be effective if you have 100 people in place and 10 of them are infected, or 25. And so the R value by itself is really important, but it's not the whole picture.
Correct. Yeah, it just, I know that's the one the Premier's referenced in his when he's been talking publicly. So, but appreciate there's lots of other pieces. The other piece that I want to ask about in this round is related to that contact tracing. And I'm just wondering if you can provide some insight as to where this, it feels like it's fallen apart, that there are far too many cases that we don't know where things are originating, which is why we can't have that type of targeted action on specific areas. So can you share a little bit about what has potentially gone wrong, and is there a way to catch up on that? Is that why we have to look at some type of approach in a lockdown to be able to allow the contact tracing to scale back up? Because it seems like other countries that have done very well around managing the pandemic have had a robust contact tracing system.
Let me take a crack at that and then hand it off to Lenora, who you, I think, are quickly recognizing is actually the brains behind this stuff. But so let me start at where you ended, which is the correct part, is that it doesn't matter whether we're talking about the acute care system or things like contact tracing. If you get exponential growth, no system is capable of keeping up with exponential growth. You think 2 months, not a long period of time, but if the thing doubles every 2 weeks, then that's 4 doublings. So that's 2, 4, 8, 16. Now, no matter how many contact tracers you have at the beginning, the chances that you're going to be able to train them and bring them on board to handle 16 times the workload within 2 weeks is essentially zero. So that's the most important part, is that we need the circuit breaker to get those numbers back to the point where contact tracing is operating at its most effective. Because if you get the numbers down, aggressive contact tracing resulting in isolation and quarantine of people who are known to be infected or who potentially are infected is another guardrail. It's another level of protection. Lenore, anything you wanted to add?
Sure. I think, it was publicly stated that AHSH have been working to increase the number of contact tracers. I think that Dr. Talbot's point that at a certain level, no system has the capacity to trace that number of cases is very true. The net effect, of course, is that we're flying blind. And so one of the goals of increasing restrictions would be to bring down case numbers adequately to be able to start, real-time contact tracing again, maybe letting the cases that, are old and you haven't gotten to yet, let them kind of just go, which has already happened, and start with the fresh cases and try to contain spread that way, because the goal is active cases and their contacts, if quarantined, will allow you to bring the numbers down quickly, and also would be the key to getting out of restrictions in the future. So that's part of the goal of a restriction. Like, you should never enter a phase of restrictions that impact people to a great degree without clear goals. And so some of the goals are numbers-based. Some of the goals, I think, might be process-based, where you're looking to get better processes back to speed to be able to give you freedoms back at the end of a period of restriction and contain things that way. And again, we do have, a much clearer view of the end game here with the effective vaccines already being rolled out. And so we do know there's a time-limited period where we have to control this and reduce excess deaths and then start to allow all the recovery to begin. So I think it becomes a lot more saleable when you keep in mind outcome, process, what you need to do by the end of a period of restrictions, and then looking for, the end of the pandemic season, if I can put it that way.
Thank you. I'm out of time, but I really appreciate that.
Thank you. Councillor McKean is next. Councillor McKean?
Thank you. I'm just wondering if you can hear me okay. My computer is acting very weird.
Maybe turn off your video just to so we can hear only your dulcet tones, and try that.
We got nothing but virus problems.
Can you hear me now?
Yes, go ahead.
Thank you. Thanks for your leadership today to our guests. It may not surprise you to hear that the hospitality industry, or some of them in Edmonton, have started to lobby for a shutdown. Because they're worried for themselves and their staff, and maybe access. They would like to see us take certain steps. And I just wanted to get clear on this. You would have us shut down fitness centers and use whatever authority we have to shut down bars and restaurants and other public businesses and assemblies. Am I right?
In broad brushstrokes, yes. For restaurants, it's the in-house dining that's the highest risk, so them continuing to provide takeout and curb service is likely to be able to be done very safely. Bars could still allow the same kind of service, but it's the in-person transmission that we're most concerned about.
And our fitness centers?
The fitness centers, once again, it's kind of important to look at the context. So if you're in a spin class, first of all, most of the restrictions, the kind of rules that we have in place are meant to be for normal activity with people engaged in their everyday chores, walking around, shopping, etc. If you're in an enclosed space in a spin class with 10 other people, whether you're social distancing or not, with the high breath rate that you have, if you're someone who's pre-symptomatic, you've been infected but don't have symptoms yet, the odds are that of transmission in that space are very, very high. If you're in a very large gymnasium and there are 10 people there and they're spaced, 20 meters apart in their weight training, and the establishment is continuing to do high-level cleaning between, they've scheduled the exercise so that you get 50 minutes and then 10 minutes somebody goes in and cleans all the equipment, then there's a potential for running it safely. Or we could just shut it down.
Yeah, thanks. Because the one sounds like a lot of discipline and the other's a little easier. And I'm interested in this, maybe looking at circuit breakers. Grocery stores was the other one that kind of interested me in one of your slides, because that becomes a lot more integral to people's lives to be able to eat, of course. And it was my understanding or my reading of this, it's not part of the equation here is time.
I can try to answer.
So if you were next or somewhat close to somebody who was contagious, risky than having a meal with them, sitting with them for 45 minutes or an hour. Is that the scientific, is that proving out scientifically?
You're absolutely right about time. I'm going to hand this over to Lenora, who's been following the literature, but I will point out that literature covers places that might not have had any restrictions at all, or had restrictions that weren't working, etc. So, Lenora,
Yeah, I think we're talking about the publication about the points where that seem to be associated with transmission. And grocery stores are usually, when they're running things very well, would appear to be a low risk setting. They have large airspace. If it's not crowded, if people are distancing, if they're wearing their masks and they're doing their hand hygiene, they should be reasonable. But a lot of those data were from very big crowded cities that might have very small crowded supermarkets. And if you look into the details, a lot of those areas were actually in like smaller areas of communities with very high transmission, a lot of essential workers, maybe a smaller setting. So I think that I would pull out the grocery question, I think, as being most of the supermarkets that we would have in Edmonton would likely be still a very safe setting, but small, less well ventilated and more crowded settings would be of potential concern. And one of the things that was done in some of those large cities was to actually look at increasing the number of places to distribute groceries, because poor neighborhoods often only have 1 or 2 stores. And so they actually looked at, expanding access so that there weren't pinch points. And that's something that would, be discussed, I guess, if you were in a part of the community that had less access for grocery services. But I think that overall, most of the grocery stores in Edmonton are likely still very safe.
So just to add to that, we're not really recommending that grocery stores be shut down, because obviously people depend on them.
Thank you, Councillor McKean. Next is Councillor Essinger.
Thank you, and I really appreciate you coming to talk
Thank you very much.
I am curious if Edmonton went through a circuit breaker, and we're going to find out later what exactly we can do or not do. Would you encourage the municipalities in and around Edmonton to follow suit? And the reason I'm asking, because if not, you could just go to a neighboring municipality and travel, which would, I think, be counterproductive.
Yeah, we would. Our major thrust from the Medical Staff Association and the healthcare workers that have been telling their stories to us is that we need to take the pressure off the Edmonton area hospitals. And that pressure is coming from the entire zone. In fact, some of the pressure is coming from other zones. So yes, we would definitely recommend that.
Okay, and I guess my other question is, the impact of those who are non-compliant would have on our numbers. So I've heard some people say, if we're going to have so many non-compliants, why should I sacrifice? So how do we, what is the tipping point, I guess, when that really makes a big difference to what we're trying to accomplish?
The only way we can really tell that is to take a look at the curve. And if we don't get the curve bending, then we don't have sufficient compliance.
So try it, and then if we don't see it, then we can readjust. My other question is, I know many faith organizations have gone to online and they've tried to address it, but not all have. So what advice would you give to faith groups out there, because they could be larger gatherings?
Well, I mean, the advice we have hasn't really changed. It's that if you're safest in your own home with limited number of contacts with the outside world. If you're going to go outside of that, you're safest outside than when you're inside. If you're going to go inside, if you're inside with larger numbers of people, and especially if they're not wearing masks, and on top of that, even more especially if they're engaged in high-risk activities like exchanging a kiss of friendship or singing in a choir, then you've increased your risk significantly. So we would like faith-based leaders to take a hard look at how they're operating and ask themselves whether or not they want the people who are participating in the service, either as officiants or as congregation, whether they want to expose them to a risk or whether for a short circuit breaker period they're prepared to go with the maximum amount of safety possible.
Thank you. My last question is about enforcement and the value of enforcement or ticketing in order to encourage, I guess, more compliance, or do you see that as valuable at all?
So enforcement is part of a suite of things that are important. The first is that people being aware there's a problem. Secondly, being aware of what they can do about the problem. Thirdly, you count on a certain amount of social pressure for people to, be gently told when they get into a setting where they should be wearing a mask to remind them to wear a mask. The other extreme is enforcement, where we start charging people and fining them. And it's important that if that's done, it's done fairly, that it doesn't target certain groups. It's important that it be done as politely as it possibly can. But it does act. We know that when seatbelts were voluntary in the province of Alberta, we didn't get much in the way of bang for our buck. But when they were made mandatory, and particularly when it was enforced by the police, then we saw a significant number of people who weren't dying, weren't being injured, and saw insurance costs come down. So enforcement has its place.
Thank you. Those are all my questions. Thank you.
Thank you. Councillor Carmel.
Thank you. Thanks to everyone for the presentations today. There's a couple of questions in my mind that I'm really wrestling with. And the first is this, that on the one hand, we've seen a somewhat minimal approach, and we've seen the numbers go through the roof in response to that approach. But my concern with what I'll call a blanket approach is that we're not necessarily targeting those spaces that we know will have an effect and will have a positive effect on the numbers, that we know that definitively. And I understand that we actually can't get to that place because we don't have the contact tracing data to support those kinds of targeted shutdowns or targeted closures. Is that, first of all, fair to say?
It is fair to say, but I would add into that the fact that we're in a period of exponential growth makes it difficult as well, because you're constantly chasing something that's doubling every 2 weeks.
Yeah, I get that. You're chasing, and so in your presentation, you've pointed to a model a report that describes a model, and as I've only had a moment to look at that, but it seems to overlay movements of people by virtue of the cell phone metadata that's been gathered, and overlaying that with places where we're seeing extreme case counts go up. So in other words, that's not a contract tracing report either. That's more of a statistical analysis. Am I right in that? Do you know?
Yes.
Yeah. And so I guess my question is, are you aware of other jurisdictions that have relied on that model or a similar approach and applied that information to their measures and seen positive results?
I can take that one if you like. It's Dr. Saxinger. That was a very recent publication. I think that there's been a lot of desire to try to target restrictions to the best effect possible. And this was, I think, a good publication illustrating how you can use data like cell phone data to identify those places. And those models did actually predict case counts in those cities quite accurately when they applied them retrospectively. I think the difference right now is that to me, that's something that you do when you are no longer having uncontrolled community transmission. That's how you keep things open. At the moment, trying to do targeted restrictions when we don't actually have good data about the current hotspots of transmission is just, again, running the risk of not getting control of things. And we do have very good evidence that the broad public health restrictions work. I mean, multiple countries have done lockdowns with various, I guess, recipes of lockdown. And we do have data on how that affects case numbers in the, ensuing 1 to 4 weeks. The first week, you can get as much as 60% of the drop in the R in the first week. The case numbers take longer. So I think the evidence does support broader measures up front and targeted measures coming out of a lockdown or out of a period of restriction. And right now, we're facing a situation where we in Alberta right now have 6 to 7 times the case rates, weekly case rates, that they have in Ontario's plan at the red zone. So we're 6 to 7 times higher than the red zone in the Ontario plan. And we are about tenfold higher daily case numbers in Edmonton alone than we were in the province, actually during the latter part of the last shutdown. And with that, we also are in a situation where we have a 10% positivity rate, suggesting that we're undercounting cases to a great degree. So even that tenfold is an overestimate. And so anything that is done, I think, has to be framed very clearly in the setting that this is the worst situation we've been in, pandemic-wise, to date, and that it is going in the wrong direction very aggressively. And so I think the prioritization again is what measures do we know work when things are really flaring like this, and then having the tools to refine it to minimize the period of restriction as much as possible.
Okay, I don't have time to ask my next question. I'll come around.
Thank you. Councillor Nicol.
Thank you very much, and thank you very much for your presentation. So I'd like to start asking some questions, trying to focus on the exit, what the exit looks like from COVID. So we have and it stands to reason, I think you would agree with me, if people understand what the end looks like, we probably can reduce fear, anxiety, and increase compliance. Would you not kind of agree with that statement?
Absolutely.
Great. So let's talk about the vaccine, what's coming down the pipe, what that implementation looks like and what the effects of a vaccine would do. And then I'd also like to talk about treatment because as we stand today, it's not just about a vaccine, but COVID treatment is also probably a big piece of saving lives. We're focused on a vaccine, but I'm also interested in the status of COVID treatments. So can you describe to me a probable vaccine, when it's going to show up, and how that distribution works, and how that could affect our numbers, hopefully in a positive way? I'm not a virologist. I keep saying that over and over and over again. So can you explain some of that to me?
Sure. I mean, we have these 3 vaccines that have shown to be effective. And what that means is that get them into the arms of people who are at the highest risk of severe disease and death. And as long as the vaccine is effective in them, they become protected. And so that will start to bring the mortality rate down. And you see in England where they started, or the UK, I guess I should say.
Okay, just to interrupt you really quickly. Protected means what? Protected means what?
Protected, well, we don't, the virus has only been around since March. So even people who got infected at the beginning, at most, have been around for about 9 months. So if we knew that they were protected, the maximum number of times we know that they can be protected is 9 months, because that's not as much experience. That's as much experience as we have. So if the vaccine provides protection like measles vaccine does, which is almost lifelong, then it means that the person who gets it will be protected and doesn't have to worry about being exposed to it again. If it's more like flu vaccine, then the vaccine will probably have to be administered every year in those high risk populations, the same way we do as flu. But that's basically what we're aiming for. Is as we start with the highest risk populations, we look at protecting healthcare workers who are at risk and who save lives, frontline responders. However the priorities are set up. And I should say that I'm speaking generally, that for the specifics, you really need to go to our brilliant Chief Medical Officer Health, Dr. Hinshaw. So what that means is that somewhere in the next 3 to 6 months, to give time for logistics and the rest of it, we'll start to see a situation in which the mortality rate due to the virus comes down, and may even see, as we move towards actual herd immunity, not the thing that's being talked about to the south of us, we might actually see a decrease in the amount of transmission. For treatment, I'm going to hand it off to Noel, but I will say this. One of the problems with the surge that we're in now, and this is already happening in the U.S., is that their treatments have gotten better. So the number of people who survive COVID once they're in an ICU has increased. But with the surge and not being able to take the same care, not being able to provide the same kind of manpower, that mortality rate is starting to increase again. Because to keep the mortality low from COVID, it's labor intensive, and that's the one thing that we're running out of. So no overview.
So I only have I have 30 seconds left before the next panelist can respond. I'd like some definitions or some metrics so I can explain to people what the exit looks like. What does the end look like before I go back and ask, we're going to have tighter restrictions?
I can try to address that too, actually, just really briefly. So for one thing, treatment is disappointing. Better supportive care and steroids for people who require ICU reduce mortality by up to 25%, but that does not keep them out of the ICU and is still a very dismal thing. So prevention is by far the best thing to do for COVID for the individual patients and for the healthcare system. From the point of view of a vaccine rollout, if it's deployed initially at high-risk people, we would still see restrictions in place as it's phased through the population, and gradual reduction of restrictions based on the current transmission numbers, which should be improving, until probably next fall when we'll have really good vaccination coverage of the population and likely have what we think to be herd immunity. Early indications are that the vaccine will likely provide lasting immunity, and so the restriction period to get things under control would be hopefully short as possible. Beyond that, targeted restrictions, contact tracing, and implementation of vaccine should keep things looking more normal through to the fall. And plus, we should also have the summer advantage of more outdoors exposure rather than indoors exposure, lessening transmission. So I think the period of worst pain would be relatively short. I mean, compared to a pandemic timeline.
Thank you. Councillor Zadek is next.
Oh, thank you very much. To be clear, is this panel recommending a circuit breaker for Edmonton?
Yes, we're recommending a circuit breaker to bring down, to bend the curve.
Okay, thanks for that clarity. So we usually hear from Dr. Sikora, who is the head of the Edmonton zone. Is he part of your organization?
Dr. Sikora is part of Alberta Health Services. He does represent the zone. I know Chris quite well. We have been in contact with him as part of the committee. He's indicated that he thinks that us staying in touch with him and allowing him to comment on our measures is as much involvement as he can spare right now during the pandemic.
Sure.
But we are in contact and communication with him.
But he's not part of your organization. We often hear from him, and he provides public health advice that we follow. So thanks for that clarity. I guess I would ask, is your recommendation for a circuit breaker endorsed by Dr. Sikora or Dr. Hinshaw?
You'd have to ask them that. They're aware, but I couldn't hope to speak for them. I will say that we have nothing but respect for both Dr. Sikora and Dr. Hinshaw. We think they've done a great job, and we're happy with them.
Albertans are quite pleased, and it's amazing the great stories and great personalities that emerge during a crisis, and I think we all have a lot of respect for them. But basically, what we're hearing is your recommendation could be in contradiction with their recommendations if I had the opportunity to ask them.
I would say that what we're proposing is in addition to what they've talked to. It's not in place of. But we're saying that from the perspective of the medical staff and the healthcare staff, that there's a crisis already in place, and it's doubling every 2 weeks.
Okay, noted. Thanks. Does any of your medical advice here consider non-medical considerations? For example, the economy, suicide rates, rates of domestic abuse increasing, opioid usage and abuse increasing?
Lenora indicated we do take that into account. I would point out to start with that there are a number of effects that both the virus has and the attempts to control the virus have that overlap. So as Lenora said, fear of the virus is almost certainly driving some depression and some anxiety and could potentially be resulting in some suicide rates. There have also been some things that have happened that would have to be factored in long after this is over by academics. So, for instance, motor vehicle collisions as a source of mortality are significantly down from what they were. So, yes, we do. But we keep coming back to this point, which is that right now, what determines whether you're going to die or not in this province is the virus. And we're trying to get it to a point where people making individual decisions and the government are in control of how many people die. And if that doesn't happen, if we don't get control, the economy is already suffering. I have a friend who runs a restaurant, has run it for more than 30 years in Edmonton. He tells me that he's down to, at lunch, he used to be very busy, he's down to 10 tables, and most of those are 1 or 2. So people are already voting with their feet.
If we could talk about restaurants for a second here, since you brought it up, and by implication of a circuit breaker, restaurants are going to be impacted. And also further to what you've said, we don't really know where the virus is spreading, but we believe, I mean, from what I've heard, we believe it's happening with home gatherings. But you were suggesting that, I believe you're saying that home gatherings are probably okay, and the rules around restaurants don't seem to make too much sense. Just for clarity, are you in opposition to the provincial rules around restaurants right now? And just thoughts around, are these restaurants that have adhered to sanitation standards and the rest, public health guidelines, and some of them have voluntarily closed, are you saying that those restaurants, and I'll throw in gyms as well, sources of COVID spread that's unacceptable at the moment?
So to start off with the social gatherings, scientific and medical literature and our own experience in Alberta is very clear that people acting irresponsibly in terms of their social gatherings are causing super spreader events. and they are, at least in part, fueling what we're seeing. So in no way, shape, or form are we advocating for people to do anything but obey what the province has already effectively communicated. In terms of picking out a sector, I believe that everybody is doing the best job that they can, whether it's in a gym or a restaurant or a bar. But the problem is that those are additional places where transmission can occur, and it's not working. It's doubling every 2 weeks. So we can continue to go on this course and let the hospital staff and the healthcare staff become exhausted and have people now not be able to get into hospitals for their heart attack or for the complication they have with their pregnancy, or we can do something about it. That's essentially what we're recommending to council.
If I could also add a little to that, I think what we've got here is a challenge between trying to support the economy and trying to prevent death. And I mean, obviously, an economist will say that there's a dollar value on human life. But effectively speaking, in the last, since pandemic has started, we've had 2 jumbo jets worth of Albertans die. And that number is going to increase very significantly unless we put something definitive in place to control the rate of spread. And nobody wants to impact on individuals' livelihoods or on the economy in general. But we're in a very stark situation, and it's only in that kind of situation that these recommendations would be made. I've just received a text this morning where basically one of the senior intensive care doctors in the Edmonton zone has indicated that we're getting 13 admissions to the ICUs per day. The number of patients close to coming to ICU on the hospital wards is now dramatically high. It's at 37. And in 4 to 5 days, the current capacity will be exhausted with a requirement to surge into another 100 ICU beds without any idea how those beds are going to be actually staffed by people who know what they're doing.
Thank you. Councillor Walters.
Thank you all for your time here today. There was an interesting piece in the New York Times today that talked about society generally maybe putting a lot of stock in the vaccines, and that's allowing people to let up a little bit. They note that the pace of the effectiveness of the vaccines really depends on the shape we're in generally. So the more cases, the more pressure on the healthcare system, the more dominance or prominence of the virus itself, it really hinders those efforts. I just wondered if you'd sort of comment on that, Dr. Talbot.
Well, it's an excellent point. I mean, the very same healthcare system that's being overwhelmed in terms of contact tracing and the ability to treat and care for patients is the healthcare system that will depend on to be able to deliver the vaccine. Not to mention the fact that if the virus is still raging, getting people together and effectively immunize them in large numbers is going to be made more difficult because of the precautions that are going to have to be taken. So absolutely, there's no question about the vaccines are a good thing, and they're the most hopeful thing on the horizon. But we need to get from here to there.
Right, and to make that even more hopeful, the behaviors of today matter a great deal. So I also wanted, this isn't really a question as much as a comment, but I really wanted to thank you for your comments about civil liberties. Our freedoms and rights have been repeatedly cited in defense of not imposing too many restrictions, but I'm not feeling very free personally these days, and I think that's an excellent point that needs to be amplified by political leaders. So just to thank you for that. And I think many of my other questions have been asked, but just confirming that it really is too late for us to install or to focus on targeted restrictions. I think you've answered this a number of times, but just to confirm that a circuit breaker is what is required to get us back to a point where contact tracing has the kind of utility that allows us to eventually shift back to targeted restrictions.
Yeah, that's our recommendation.
Okay. And then so there's different kinds of circuit breakers, though, I guess, and I just want to understand, like, there's different severity of a lockdown. There's the kind of lockdown where you're allowed to go outside of your house for an hour a day and maybe to the shops an hour a week kind of lockdown. So maybe just add a little more color to what you mean precisely by a circuit breaker in our context here in the Edmonton zone.
In public health, we work with everybody who is willing to work with us to prevent disease and injury, promote health, prolong lives. But we recognize that, every context is different. So the kind of discussion that you were having at the beginning of the meeting about what kind of powers you actually have, we recognize that you can only act within those powers. And so we're not trying to be prescriptive and say, do this, don't do this. What we're doing is saying, we need a circuit breaker. We need to make clear to people that this is a very serious situation and that the highest risk is when you're indoors, in groups, with or without masks. And so any kind of targeting that you can do in that area is going to be helpful. And I would say, you mentioned the point about rights and freedoms. I'm a medical microbiologist by training. That's what I did before public health. So there's never been any question in my mind that this isn't public health versus the economy. This isn't, individual liberty versus the government. What this is the virus against all of us. And the virus doesn't care about your civil liberties, and it doesn't care about your healthcare system. And as a consequence, what we're trying to get across is, and it doesn't care whether it's targeted or whether it's a shutdown. If we do an effective shutdown, then the virus will tell us by infecting fewer people. And if we do that with targeted stuff, it'll come down faster. So this isn't a fight of one versus the other. We're just saying that one is a lot more useful right now.
Well, thank you for slaying that unfortunate dichotomy. I appreciate your time and your work. Thanks, Mr. Mayor.
Thank you. And Councillor Banga got bumped down on the list, so we'll go to him next.
Thank you, Mr. Mayor. My sincere thanks to everyone, especially the guests. A few questions. When you tell people all these new measures we are putting in place, and often they ask us that these restrictions we are placing have no effect, as the number of cases keep going up or at least staying about the same. What would you tell us to tell them?
Well, I would start off with getting them to remember that in the spring we acted early and we acted with a full slate of measures, and we have avoided the kind of deaths and hospitalizations and crumbling healthcare systems that they saw in Italy and France and New York City, etc. And so people made good choices back then, individuals and organizations, and we know we can do it again. So that's where I'd start. Secondly, I'd say one of the reasons that we're not seeing the effect, and I think that they're right, they're looking at the numbers continuing to go up the same way we are, and they're drawing the same same conclusion that what we're doing isn't working. And so I would agree with them on that, but I'd point out that we're chasing something that's doubling every 2 weeks. And it's not something that a lot of people have experience with. Noel would have had the experience in Katie, Lenora in her infectious disease experience would have had that I've had. It's hard to catch it from behind. You have to get out in front of something that's doubling every 2 weeks, and that's what we're proposing. So I would say to them, let's try it. Let's try it as a lockdown or as a circuit breaker, call it what you want, for a couple of weeks and see what happens.
Okay, and there is a lot of talk about contact tracing. Could somebody actually explain it to me, what it is and how does it actually work?
Lenore, do you want to take that?
Sure. So in contact tracing, when someone's notified, actually, it really is unclear with the mask on. When someone's notified that they're positive, they're contacted by a contact tracer who goes over their recent movements, who their contacts have been for the period of 2 days prior to them developing symptoms, and if possible, identify any large venues that they might have been at before that, and then try to contact everyone that they would consider to be a potential significant exposure to that person while they were infectious, which again can be 2 days before they develop notable symptoms. This can be going back a bit of a distance, so people should actually be keeping track of where they're going and who they're seeing in case they should become positive. The people who are close contacts are then asked to isolate themselves for 14 days, which is essentially the incubation period, the maximum incubation period of the virus, because they could develop symptoms after that exposure at any point through those 14 days. And so, and if they do develop symptoms, they need to be tested, and then they would have to isolate for 10 days, which is the period of time that people are felt to transmit the virus themselves. So it's quite a labor-intensive process that requires many, many phone calls and, cooperation. And for that reason, the contact tracing investigations, you really have to have a big workforce ready to do that. And contact tracing apps can assist in that. In some jurisdictions it has. And it's a key part to continue to basically halt outward spread as quickly as possible. Timeliness is incredibly important.
Thank you. So kids in schools, some of them are still going there, and they have some contact with each other. Then they come home, have contact with their siblings and their parents, who in turn may be going to work later on. Could you comment on that? Like what can be done or what should be done?
So I can comment that the UK lockdown, which they did November 5th and has had a good effect for them, they kept schools open, so essential shops and supermarkets and educational venues were still open for gatherings. Pretty much everything else, with the exception of outdoor exercise, was stopped, just takeaway, et cetera, et cetera. And they did actually see an effective decrease in transmission with schools still being open. There's a few reasons for that. Children appear to be less likely to get symptomatic infection. They also appear to be less likely to spread infection, particularly to adults. They can spread amongst themselves. And whether or not schools drive transmission in the community or reflect it has been a source of some, I guess, scrutiny in terms of evidence, and it's not yet clear. I think most people still think that schools reflect the community transmission, not necessarily amplify it. Certainly there's a tipping point at which having schools open becomes a net negative and very difficult to sustain, but I think that that's really a public health call. And the main thing is the kids themselves remain quite safe. The question is whether or not they might be exposing their families unduly to infection. So I don't think that that's Edmonton's own Medical Staff Association call.
Thank you.
Thank you. Councillor Katarina?
Thank you to everyone for their presentation. So it's fairly clear to me that we know that we don't know many things. What we do know is what we're dealing with, and that's COVID. What we don't know is the where and when and who and why, those sorts of things. So with the idea of a circuit breaker, it seems like we're talking about 2-week intervals, which is, for me, it's a little bit challenging that we pick that 2-week. We'll try something and then maybe we'll try something else in 2 more weeks. So if something looks like it has a possibility to work in 2 weeks, maybe, what are the possibilities that it would work in 3 weeks or 4 weeks? What sort of results? Why are we focusing on such a short period of time when we know that from past experience from last March to now, those sorts of timelines haven't worked?
So that's a really good point, and I wouldn't want to leave the impression that we're saying that everything is going to be hunky-dory in 2 weeks. What we're saying is that 2 weeks is about the earliest you'd expect to see a signal in terms of decreased number of cases. And so if it was working at that point, you'd say, if it was working really well, you have the option to, maybe think about doing something differently. Or you decide to wait another week and make sure that it's actually starting to flatten, or better yet, come down, and then make another set of decisions. But what we're saying is 2 weeks is the earliest you can possibly know whether or not it was working.
Okay, that's good clarification on that, because it seems like many of these measures, first of all, mandatory seems to be working much better than suggestions to people. So we know that. So I guess the idea to make things more mandatory sooner would be better. And I want to ask Dr. Bakshi this, because you are a doctor and you're there, you're at the hospital, you're there day to day, you see all these things in that. If you could, given our restrictions, you're talking to a municipality here, not the province, given what we can do at this point, what would you like to see us do? Like, from your perspective, what do you think would be the most effective if we started today? We've done things in the past, some worked, some haven't, but if you started today on recommendations, what would you actually suggest we look at?
Kind of similar to what the other folks have been mentioning, I think areas that we see large congregations that either you can't physically distance, so casinos, indoor restaurants, bars, those kinds of things, I think those are probably the fastest things that we could take care of. And I think a lot of folks in the hospitality industry are already thinking like that. There's a lot of restaurants that have voluntarily gone to curbside pickup only. And so I don't think it's a huge stretch of the imagination for those types of businesses to be able to do that. And I think the council's been doing a phenomenal job of messaging out to Edmontonians, but I think continuing that message that healthcare and hospitals are in trouble and that we are facing crisis with capacity. And still, I think, we can look at restrictions at public places, but even still compelling the community at large to follow these restrictions and to follow these. And I think one of the other councillors asked about municipal areas outside of Edmonton. I think also spreading the message that it's not just Edmonton zone, and that for our hospital system to be able to keep up, for us to be able to serve the north zone, the central zone, areas that we take patients who need tertiary care, we actually need more than just the city of Edmonton to cooperate.
So with the idea, we've gone mandatory before the province did in certain areas, so have other municipalities, but the fact that not all municipalities act at the same time. So I guess I'm taking from that mandatory should be provincially, so that way it takes care of the different zones, that everybody is working under the same conditions in that. So the other thing I wanted to ask was, best case scenario, if everything goes well, if everything were to go well, with the restrictions in place, with future restrictions, with the vaccine, with all these things, if everything went well, just a timeline, where would we be? Like, what's that timeline? Somebody had mentioned September, possibly, that we're looking at this until September. Can you give me a more definitive timeline if everything went well? Things are going to go wrong, but if everything went well.
Well, if I could do that, I wouldn't be talking to you. I'd be in Vegas right now, making lots of money on the sports book. But if we get to some combination of effective measures, I think we could start to see the curve flatten and come down by January. And depending on the logistics and everything else, I think we could see and this is optimistic, and Lenora will probably slap my wrist for this, but if we were to get sufficient vaccine into the high-risk population by the end of the first quarter, by the end of March, then that coupled with summer and people going outside, I think we would be a significantly better place than we are right now. And that by September, and it would continue that way until September. And so depending on how many meals we've gotten in the arms, we might see another smaller surge in September like we do with flu, but that's my best case scenario. Lenora, did you want to say something that was actually based on fact?
I don't have a crystal ball either. I would say that no matter how you cut it, December and January are probably going to be terrible within the healthcare system. The degree of how terrible it is yet to be determined. I think that, over the early spring, we would see rollout of vaccine, decreasing death rates, decreasing case rates. I think that, by mid-spring to early summer, we would actually probably have a summer that would be experienced much like last summer was, which was, I think, tolerable with some restrictions that may have to wax and wane depending on the rate of vaccine rollout, and that things, would be actually kind of okay by summer. So it's really looking at a full quarter of a real battle. And like I said, the severity of that is yet to be determined. I kind of think we're at history will judge us harshly stage in terms of if you act sooner when things are going up very quickly, you really do affect the length and the peak of an epidemic curve. And I think that's why we came here today, because although obviously restrictions across the province being cohesive would make it easier and avoid squeezing the balloon so people don't leave one place to go to another place to do things, I think that that's the kind of urgency which we're feeling about this right now. But we do see a much better time coming.
Thank you.
Thank you. Councillor Nicol, could you take the chair?
I have the chair.
Thank you. So, Dr. Talbot, only you have the experience here of having provided these kinds of briefings as a Chief Medical Officer of Health. And I ask this question not in the least wanting to undermine the important work of the current Chief Medical Officer of Health, but in general terms, are these the same kinds of data points and same kinds of science that would be presented to decision makers in a situation like this in your experience?
Sorry, I wasn't hesitating to answer. I had the mute on. Yes.
Okay. And I mean, I hope that's reassuring to the public too. And I'm very grateful to have the opportunity to hear that kind of presentation here and for the public to have the opportunity to hear this kind of information. Now, we're very interested in evidence-based decision-making and data-driven approaches to public policy here at the city, as you know, and I just want to run through the data that you put before us here in general terms. One, we're still seeing exponential growth. Any R above 1 represents doubling over some period of time. It's just a question of whether it's 2 weeks, 3 weeks, 4 weeks, but any R greater than 1 is still exponential growth. Yes?
That's correct.
Okay, and it may be a bit slower now thanks to the measures from 2 weeks ago, but we heard Dr. Hinshaw herself indicate yesterday that in her estimation, the virus is still R above, considerably above 1. That's your understanding too?
Yes, but the data I have does not show bending at this point.
The
Mind
bending
you,
that we
it is
need.
2 days old. But
Right. It might have bent a bit, but we're not seeing it flatten at all.
That's correct.
There is a lag, understanding that, but with waiting to see the lag comes the risk of overburdening the system is the other data point that's clear today, or consideration. Positivity rates anywhere above 5 reflect a reality that the virus is there are probably much more active cases out there than have been tested. Do we have? Is there any evidence as to what that real number might be, or any study that suggests? Because it's one thing to make an assumption that 1 in 100 people out there might have it in certain parts of our city, which is true with some of the districts within the city being 900 plus. Essentially 1 in 100 people out there has an active case of it in parts of our city. But that's the folks who've been tested and are in the system. Those are the known cases. There are unknown asymptomatic cases out there of a certain amount. Is there any way to make any educated assumption about what that might be? Not to be alarmist, but to be realistic.
I could try to answer that.
Go ahead.
Yeah, I mean, I can try to answer. It is kind of the question. I think the things that are concerning are, we know jurisdictions with a high percent positivity, we're undercounting cases to a great degree. We know that people who have had symptoms or minimal symptoms before can actually continue to carry the virus and still test positive later. But when you have actually all the numbers going up, the cases, the percent positivity, 1 in 10 people lining up for a test in Edmonton right now is positive. We know that we're undercounting, and there are different ways to estimate those numbers. I don't think that I've seen anyone try to apply them to our population. It's something that probably could be done. But I would say that, given that we had percent positivity under 2% for basically all of the summer, and now our percent positivity is fivefold higher, that we could be underestimating by easily fivefold. And so that tells us that the ceiling on the number of cases right now is much, much higher than it ever has been.
All to say the virus is winning right now.
Absolutely.
That's correct.
Now, to stop it, or at least try to bend the curve to get R to 1 and stop exponential growth and relieve the burden on the healthcare system, lockdown can mean many different things. And I want to refer back to your slide, because it can mean, and I think a lot of people hear it as shelter in place, which some jurisdictions have done. But I'm not hearing you advocate for that, because K-6 is very, very important. Certain gathering places with the right capacity restrictions, like grocery stores, maybe libraries, other outlets for vulnerable people, it would be contrary to the public health interest to close those. So I just want to be crystal clear, you're not advocating for a shelter in place full lockdown. You're asking for a lockdown or that is to say closure of certain super spreader, high transmission vectors, casinos, bars, in-restaurant dining, gyms and sports centers, faith assemblies, limited numbers for indoor spaces and stores, and maximum office work from home. Those are your specific recommendations?
Yes, I only have one caveat on that, which is that we already have members of the population who've decided to shelter in place. I doubt there are very many 80-year-olds out there with comorbidities who aren't already shelter in place, but that's not what we're recommending to council, but it may be the right choice for some people.
Well, mandated versus free to do so, I think, and encouraged to do so in the case of vulnerability is the distinction there. So anyway, I'm out of time.
I'll return the chair.
Thank you. Is there anybody else on the first round? I can't see the whole screen. Okay, so we're into the second round here. I'd note this delegation has other engagements beyond noon, so we only have them till then. We can extend as late as 1 if we need to get through the other items. So I think we've got enough time for who's on the list here. I've got Councillor Paquette, then Councillor Nicol, then Councillor Henderson, then Councillor Banga, then Councillor Walters, and then we're probably out of time with this, and then Councillor Knack, and that'll take us to when that we have to release the panel to their other duties. So, Councillor Paquette, go ahead.
Yeah, thank you. So what I'm hearing is that shelter in place or shutdown, as far as is possible, to the point where it might be bumping up against other negative impacts on health, but go as far as we can until we reach that point. So, for example, keeping K-6 open, because we know, unfortunately, that some homes have a problem of domestic abuse.
Right, and we also know K-6 is really important to kids. I mean, a kid year at that age group is like 7 adult years, if we can use an inappropriate comparison.
Yeah, I've got 2 kids in that system, so I understand.
And it has effects on people's employability and a variety of other things. But yes, if we're going to be consistent, let's say that what we're recommending is a circuit breaker with the precautions that you talked about in place to try to reduce the damage.
Okay, so that's an interesting one, the employability, because I think about the about consumer confidence, about people's willingness to go out into the community, and there are some who are more than willing, but there are many, many more who aren't. And this is having an impact on businesses, on restaurants, and all sorts of areas. And so all of these places are experiencing a slow bleed, and they have been for a long, long time. So this circuit breaker idea, this shutdown idea, basically you're taking a wound that's been bleeding out, and instead of just packing it full of the patient full of antibiotics for months on end, just deal with it. just fix the wound. Is that what I'm hearing?
Noel has more experience with wounds than I do, but that sounds about right.
Again, if I could comment on that, I think if the circuit breaker technique is implemented properly, and you can get the R value down below 8 and perhaps the infection rate, new infection rate down to 300 per day, then there's a period of time in which the public can live relatively normally. As long as they understand that probably at another time, maybe 3-4 weeks, it may be necessary again to put down a circuit breaker. The length of each circuit breaker depends on the height of the curve at that point in time. The higher you let the curve go, the longer the circuit breaker is going to have to be to get things to that point where you have some control, that you can let people out and mix and live normally again. The challenge is that I think as you've said, we've had half measures which are tiring and ineffective and affecting the economy. And I think that if you had a circuit breaker where people could get out, they would buy the things that they weren't able to buy during the lockdown during that free period.
Thank you. Thank you. Yeah. So that brings me to the examples we have around the world of jurisdictions who have shut down and effectively ended the threat of COVID, which means that people are no longer dying. There's no businesses gasping for life. There are no patients gasping for life because of inaction and the impact of COVID. So Australia comes to mind because we're getting a lot of images from Australia where people are living life as normal. I just want to read this really quickly. Their 4-point plan. Governments should be explicit about their goal of 0 active COVID-19 cases in the community and their plans to hit this target. 2, governments should be clear to the public about which conditions under which restrictions will be phased out or brought back in. 3, governments should improve public health efforts. 4, once Australia gets to 0 cases, governments should use frequent testing and international quarantines to seek to stay at 0 cases. Point 3, just to be clear, included lots of COVID tests, fast contact tracing, mandatory masking, and economic supports for people forced to miss work. Now, as a municipality, we can't do all of that, but would that basically solve our problems both economically and health-wise?
Well, first of all, start where you ended. We can't do all of that, but you can do some really important things to help bring that about. I think the goal of eradication is a worthwhile goal, but difficult to do in a place that's not an island. And
sorry, I just need to interrupt you. There are a lot of places that have done this that are not islands.
No, it's true, but many of the ones that have been most successful have been islands. And the point that I'm trying to get to is that people had to be willing to put up with a lot more restrictions. I mean, Melbourne basically went to shelter in place for almost 4 months. And I just don't know how it would be great to practice in a public health setting where you could do that.
So the question becomes, what's more economically and health-wise feasible? Shutting down for a couple months or stretching it out over longer than a year? Where do we experience the least amount of suffering? Where do we get the most reward?
I'm sorry, go ahead.
I could offer a comment there. I think that the concept of COVID-0 is really an attractive one to a lot of people. I think that the feasibility of that really becomes something to talk about once you have things under control. Because if you have some, basically an idea of the number of trends and you say, we're in this place right now, this is our transmission, and we really believe if we lock down for X amount of time longer that this is a feasible goal. Clearly, that would be the best thing to do. But our time horizon now is a lot shorter because we are just trying to get through to a vaccine. So I think that that's kind of a medium-term question. I would not say that it's not a good idea. I would not say that it is a good idea based on what we know right now. But we have to get to a point of controlled transmission to even consider it. And I think that at the end of the day, that truly is a provincial public health decision. It would never be something that could be carried out at the level of lovely municipality, because it would really require a much more stringent approach. And I mean, everything we brought forward today is really kind of geared to the place that you are and what we think, reasonable possibilities are to take as a community rather than as a province. And so, we just have to frame things in feasibility. But I do understand that that's a very attractive idea. I don't think that it's prime time to discuss it.
Yeah, no, thank you very much.
Thank you. Councillor Knack had dropped off the list. He's next.
So just to confirm so that everybody can hear this, the list in eScribe is correct. Ms. McCary is going to log off the public display and log back in. So it's Councillor Knack, followed by Councillor Cartmel, then on to Councillor Nicol.
Okay. Councillor Knack.
Thank you, Mr. Mayor. Just a few more questions, and I think maybe to Dr. Talbot specifically, because I know Councillor Zadek was asking you a bit earlier about if the recommendations you're making go against what Dr. Hinshaw might be doing. And the challenge is that, from what I understand, and you used to do that position, is that those recommendations may be being made to the provincial government, but we wouldn't know that, correct? So in your role, when you used to do that, you would provide that advice, and then the government would decide hearing that advice in private. Is that correct?
I think Dr. Hinshaw has addressed this a number of times, and I would agree with her that you make your recommendations and then the government makes their decisions based on those recommendations, but not necessarily completely following them.
Which is why it's tough to say what her opinion would be, because she has shared that with the people who make the decisions, and then they use other data to help inform. So one might suggest that if you, who has also served in this role, are coming to this conclusion, we don't know, but that's a fair. There's value in considering what you're putting forward, because this is the exact process you would have followed if you were in this role at that time right now.
Yes. Yeah. Although I have to say that having people like Lenora and Noel and the rest of the committee is a welcome addition.
Absolutely. It gives us more people to bounce ideas off of and to help inform these recommendations. So no, that's really helpful context just to know where this is coming from. Yeah, this is a little different because normally, like, we're doing this all in public because most of what council does is in public, but this isn't normally the process that would be followed from a provincial or even federal context for that matter.
Yeah.
Okay. My last question, and you touched on it in your slides, was the long, I think you referred to it as the long haul COVID impacts. And so can you elaborate a little bit more, whoever has the information on that, on what we're seeing so far? Again, we don't have a lot of data yet because we're only 9 to 10 months into this. We've seen some stories recently about the impacts to people who have contracted COVID in March and what they're dealing with now. But do we have an idea of, are some of these long haul impacts potentially now going to be with them for the rest of their life? Do we have any type of indication as to that yet? Or what more can you share about the long haul impacts?
I can try to take that one. It's Dr. Saxinger. There's a lot of work going on right now to try to kind of figure out the frequency of long haulers. It doesn't necessarily seem to be based only on the severity of illness. Mild illness can result in prolonged symptoms too. There's also a lot of work trying to figure out the duration. Of course, we've only had the virus on the planet for less than a year, and so it's an open question. Looking at similar conditions that seem to be multi-system and no longer associated with active infection, but can occur after infection. There are other medical scenarios that are similar enough that it is entirely possible that people could have a fairly significantly prolonged period of ill health after COVID, and we don't necessarily have a great handle on the exact reasons why or the best treatment for it, although, even within Alberta, there's work going on to try to find and follow patients to explain that better. It certainly is a risk that more people than we expect could have lasting effects after the pandemic.
Yeah.
Nija, did you want to say something about what you've seen?
Yeah, so I was going to speak to similar to Lenora. I don't know long term in terms of months, but we can see in hospital these patients, unlike influenza, they are deconditioning very, very quickly. And there's a significant COVID anorexia, we call it, where their desire to eat is gone within 24 hours of coming into hospital. And so they end up becoming very malnourished within 3 to 4 days, requiring nutritional support. And often the acute phase of their, if they make it through the acute phase of their illness, majority of their hospital stay is actually the rehabilitation piece. So average length of stay estimated at this point for a COVID patient in hospital is anywhere from 14 to 21 days, depending on if they've been in ICU, which is significantly higher than that of an influenza or any other respiratory virus.
Last question. Are we seeing these long haul impacts in people with comorbidities, or is it in people who are completely healthy, or is it across the spectrum? It's sort of, it's happening to anyone at this stage.
Yeah, I mean, in hospital, we're seeing it in anyone. Certainly those with comorbidities or with diabetes are certainly having longer recovery times, but we're seeing it even in patients who have no other past medical history.
Okay. Thank you very much. I'm out of time. Really appreciate your help on this.
Councillor Cartmel.
Thank you. So first of all, thank you for the answers to my previous question. I understand and accept that the time for targeted measures is past. I want to put a couple of notions in front of you, and then I want to ask a question around them. One is that, and Councillor Zadek touched on this, is what some are calling the pandemic echo, or an echo pandemic, the knock-on and long-term effects, not so much of the symptoms of COVID, but the mental health aspects, potentially the, perhaps some of the substance abuse knock-on effects that might result from that. So that being one potential concern, and the other that further restrictions, further, call it lockdowns, further measures tend to punish those that are already complying with the measures put in place. And that, the more problematic actions of some, which are resulting in the ongoing spread, those that are not following the advice offered so far, will continue to essentially not follow that advice, whether it's because they don't see an end date, they don't see an end to the measures, they simply just don't have the capacity to comply anymore. So with those two thoughts in mind, my question is around the Ireland experience. And does the circuit breaker approach, does that approach that includes some sort of defined endpoint, whether it's a metric or it's a date, does providing that information that there is an end in sight mute those other effects, either the echo pandemic effect or the greater compliance effect, or perhaps both?
If I could answer that last question. Again, based on what I can see that happened in Ireland, the population are more willing to accept it if they realize that with compliance and the infection rate coming down, the R value coming down, that they can get back to a period of normal life. On the other hand, there are also individuals who don't comply. And so in addition to those who comply, it is necessary to have fairly significant enforcement. And that has been the case in most European countries where enforcement has been fairly stringent.
So there is potentially a more significant enforcement component than we have here. Is that what I'm hearing?
Significantly more than we have here. Not exactly lockdown, and schools keep going in Ireland, but there are geographic restrictions where individuals are not allowed, interestingly, beyond about, depending on how serious it is, 5 to 10 kilometers radius from their home.
I see.
So I would approach this from and add a slightly different direction to it. In my experience dealing with crises in Alberta, and I was there with forest fires in Fort Mac, H1N1, and floods in the southern part of the province, the two things that really psychologically impact people as individuals and groups in those crises are a sense of uncertainty and a sense of lack of control. And one of the things that I think the circuit breaker approach, where you hit the brakes, you pump the brakes, you come off the brakes, you pump the brakes again, is it brings a sense of certainty back. If we bring the numbers down in the next 3-4 weeks, people will experience a sense that they're back in control of their lives and that they can go after that period and do their shopping, do whatever it is that they want to do. And it gives them a sense of certainty that we did it once in the spring, now we've done it again, so we know that we can control this. And I think those two things, reestablishing more certainty about what it is we want to do and why we're doing it, and giving people the idea that they're back in control are pretty important to both the things you talked about.
So repeated circuit breakers and repeated cycles of modest success in terms of, working towards the end of that circuit breaker and having a reopening, so to speak, does that lead to a greater sense of control amongst people? Is that your premise to some degree?
Yes, because otherwise you're in a situation where you're continuing to do things that don't work. It's a death of 1,000 paper cuts, and you don't know how long it's going to go for and what the criteria would be. Whereas here, you step on the brakes, you start to see the slowing happening, then you don't step on the accelerator, you just let it continue to glide, or continue on the brakes if you need to get further down. I'm getting kind of lost in this metaphor, but the bottom line is that once people learn that they've got control over it a second time, then it gives them a sense of certainty that, if we have to do it one or two more times before summer arrives and everybody's back to outdoor dining and numbers come down and positivity rates is back to 1%, and vaccines already protecting the most vulnerable, then I think there's a sense of hope attached to that strategy.
I agree. Thank you. Appreciate your comments today, everyone.
I think we've got time for two more. Councillor Nicol?
Well, I won't take all my 5 minutes, Your Worship, but I'm going to ask kind of a very obvious question that's been by my constituents, even my own household. We've talked about this. So your recommendations are different from the province's present position. How so?
They're different because we're moving away from a targeted approach to more of a circuit breaker, with the understanding that if the circuit breaker works, then we can take the pressure off the healthcare system and we can reestablish things like contact tracing.
I certainly understand the term used, circuit breaker, but let's talk about the mechanics, the strict mechanics that the province has one set of mechanics. You're advocating for a different set of mechanics. Is that not what I understand today?
We're saying that the situation in Edmonton is deteriorating rapidly and that we're going to the people who have authority in Edmonton and the responsibility to look out for the health of the citizens and the healthcare system to ask them.
Sir, no one is arguing that point. The point is, though, is when I have to explain it to people, the mechanics of the situation. What is in, what is out, what is appropriate, what is not appropriate. That when you clearly define, as you can appreciate, as you clearly define a situation, then you take out that guesswork, you remove the fear, you remove the anxiety. And again, it gets back to that exit outcome kind of approach that we want to do. So I guess, again, the question today, in terms of the mechanics, what are you advocating today that is different from the province's mechanics that are already existing?
We're suggesting increased restrictions on indoor dining, bars, restaurants, gyms, and places of worship.
Okay. Is restrictions mean closing?
It could. It depends on the kind of power that you decide you have as a council and your debate as to what the best way to get support from citizens in doing this is. But certainly, if I was an owner of a restaurant right now and I was concerned about my staff and my customers, I would be looking hard at going to at-curb and delivery service and shutting down indoor dining.
Okay. It really does help when you provide those kinds of definitions. So the last question is, given that Councillor Katarina's talked about it a little bit and some other councillors have talked about it, isn't this a provincial, they see the same sort of data? They see this, that you have presented here today, I'm assuming as much. Why have they chosen not to put in these kinds of restrictions to date?
You'd have to ask them, but I'm here representing as a co-chair of the Edmonton Zone Medical Staff Association and the healthcare workers who put our trust on
certainly
communicating to you the stress they're under.
But you can certainly see the question needs to be asked. Certainly, I think it needs to be asked. So thank you very much.
It is possible that we may hear more from the provincial government this afternoon.
Councillor Henderson?
Yeah, my apologies for dropping out before. My modem betrayed me. But there was one, I heard, I think most of, I got the full 5 minutes in, and so I may have missed a tiny bit of answer at the end. But I had one more question around the behavioral piece, because my question is around compliance with rules, not just the voluntary compliance. And if we have any information, if we're going to do some more specific things, the ways you can do them because we're not going to be able to police everything. We need some voluntary compliance to this. So if there's any advice you can give, I heard clarity is one of them. But if there's any other kind of advice, because I suspect the population, in terms of that social license, I think, Dr. Talbot, that you've been talking about, they're not in the same place they were in March. So any advice on how we can move forward to get the highest degree of compliance with any restrictions we might bring in?
So clarity is important. Conciseness is important. It's important that the recommendations make sense to people, that they're internally consistent. It's important that the urgency, the sense of urgency is communicated. And I think, as a number of the councillors have said, the more it's clear that this is not going to be something that's going to last forever and vaguely fade away at some point, that council has a real exit plan in place, and that there is hope on the horizon. People will do things if they have hope, and if they recognize that what they're doing is really, in the long run, protecting themselves, their neighbors, their friends. I'm sure you have professionals on staff who would be doing those things. And I think a sense of concern for everyone. We have sacrificed so much. Whether you've lost a business, you lost your job, you lost your grandparents, you lost the chance to attend your prom, we get it. We just get it. But you just need to hang on a little bit longer, and we'll be through this, and then we can bore our grandkids about how we lived through COVID the same way our grandparents bored us about the Depression.
Great, thank you very much. That's very helpful.
Thank you. We might have time for one more. Councillor Banga?
Thank you. Just a couple more quick questions. Initially, when the whole thing started, Edmonton had a relatively low number of cases. And I guess the tide has turned, now it's the other way around. Could somebody comment on where did we go wrong? We had the same measures as everybody else, if not harsher.
In the beginning, Edmonton's performance was world class. I mean, in terms of keeping the number of cases low, and in what was also really obvious was keeping the mortality rate low. In contrast, Calgary Zone and South Zone had more problems, and many of them turned out with contact tracing to be located to a result of super spreader events that had happened, and responded well eventually to targeted approaches to the businesses that were responsible and the social activities that were responsible. Throughout that, Edmonton continued to do really well. But most experts around the world predicted that once schools were back in, and in particular, once cold weather returned and people had to go indoors, we were going to see a surge. And you're seeing that everywhere in North America and pretty much everywhere in Europe, except those places we're fortunate enough to get to COVID zero. And so I would say that that's where it started. Why it's worse right now in Edmonton, we would need better and more complete data out of contact tracing to be able to give a good answer to that. But I don't think it's because Edmontonians don't care, and I don't think it's because they've given up. I think that with the leadership of this council and of the mayor, as I've said many times in the last 3 weeks, we can bend that curve.
Okay. Question for Dr. Bakshi. I don't mean this in a negative sense. I know hospitals are working 100% of their capacity right now. We know there is no cure for COVID. So what happens to these folks at the hospital?
So you're right, the care is supportive. We are providing, depending on what they come in with, if it's respiratory symptoms requiring oxygen, we have some tools in our toolbox, such as antibiotics and steroids, as Dr. Sexlinger had alluded to earlier. We are trying non-pharmacological therapies, such as proning patients to help improve their oxygenation. We are at all the sites of the COVID units. The reason that we have separate COVID units is to be able to have specific protocols on how to treat these patients. And what we've learned is that they decompensate quickly. So we need to have increased visualization, both by the physician and the nurse and the RT, respiratory therapist. We need to be doing early interventions to decide if these patients require intensive care unit, if they require higher flows of oxygen. And so what we've learned about COVID is that if we can intervene early, we have a better shot of having a good outcome or recovery or improved outcomes for these patients. But we are also seeing that these patients are deteriorating so quickly that we often don't get the chance to provide that care. And so one of the things that struck me about my week last week is the number of times I've had to call families after only meeting their patient for 6 or 7 hours to let the families know that their loved one is dying. And so it is critical for us to be able to intervene quickly, and we can't do that when we have the volume that we have.
Thank you. And one more question is isolation period. Originally, it was 14 days. I think it has been brought down to 10 days now. Do we know enough about the virus now than before? Why is 10 days?
I can take that one. So just making sure we differentiate, quarantine is 14 days because of the incubation period of the virus. Isolation is 10 days because of improved data indicating that most people do not actually shed or spread viable virus capable of infecting others, really beyond mostly the first week of infection. There are a few notable exceptions to that. People who have really severe immunocompromise, like transplant patients and are critically ill, can have, infective virus for much longer. But the vast majority of people really don't spread infection after the first week, and most people spread infection the most 2 days before symptoms and 5 days after it. So that's trying to be realistic, and I think that we will continue to get better numbers on that, because obviously targeting any restrictions on an individual to the period where it's most important and most crucial is part of what we can do to make this livable. But at the moment, yes, that is the rationale for any changes in time. It's based on newer knowledge and better data.
Thank you.
Thank you. Right now, we're just about out of time. Councillor Walters assures me he has but one question for you all, if you can spare a couple more minutes. I do need a motion to extend. I'm going to suggest till 1. That may not get us to the finish line, but
Second.
Thank you, Councillor Knack, seconded by Councillor Paquette. It'll buy us some time to figure out when we'll extend into other times today or later in the week. So I'll just seek unanimous consent on extending orders. I know a couple folks have conflicts. So regrettably, but Not hearing an objection, orders are extended until 1. Councillor Walters, with your pithy question for our esteemed panel.
Thank you. So enforcement appears easier when restrictions are more expansive and clear, as opposed to enforcing a hodgepodge of half measures, as has been suggested. Someone mentioned earlier that it's difficult to target enforcement or maybe target certain groups. So I'm not necessarily asking about certain groups, but is there a way in a circuit breaker, in the event of a circuit breaker, to target enforcement and to understand where non-compliance is more likely to appear, so that we can be more effective at dealing with these trends?
Let me just say, first of all, that I have been impressed with the depth and intellect behind all of the questions today. That one is a little more difficult to go into and do justice to. I mean, I would say that in general, in a circuit breaker, because things are clearer cut, if people are violating the rules, there are fewer of them to enforce. When you have lots more places open, it's really hard to determine which ones, as someone said earlier, might be the bad apples. Whereas with the clearer, more restrictive things in place, it becomes more obvious who it isn't following the rules, and then it should be easier to enforce. That's kind of my top of mind response.
So inherently it's easier if the rules are clearer and more restrictive. I get that. And I think that's a question for our peace officers. But thank you all. I appreciate your enormous passion and commitment to this and brilliance. Thank you.
Do you want to move receipt of information of 5.1 and 5.2?
I will do that, Mr. Mayor. Thank you.
Second.
Seconded by Councillor McKean. Let me just test unanimous consent on receipt of information. Any objections? Not seeing any. Then with formal gratitude for the information you've provided and the work you're doing behind it and on the front lines in some cases, thank you from the bottom of our hearts. So we'll release you back to the other things you have going today. We'll now pivot to, I think we can get a quick, can we get a quick summary on 5.3 and then go into 5.4?
Yeah, we can do that. We do have a presentation, but maybe what I'll do is I'll just go over what we're considering from a bylaw perspective.
I think if you have a presentation, just so that if there's visuals or anything else that goes with it, I think let's get the presentation, hear what that option is, but maybe before we ask a bunch of questions about it, we can go in private under 5.4 and get a bit of context as well. But let's get the presentation, and before we give any direction on it, we'll have an opportunity for questions. But I think important for us to get some 5.4 information too before acting on 5.3. So let's get 5.3 on the table and then bring forward 5.4 and go in private is my recommended approach. So go ahead.
Thank you. So as I mentioned, we've been looking at options in response to the number of concerns raised by the medical community, and thanks to the folks that were here today. We considered options to supplement the restrictions that are put in place provincially. We considered the powers that we would have under the Emergency Management Act. As we've shared previously, declaring a state of local emergency allows the Emergency Management Agency to access certain powers. None of the available authorities under the state of local emergency, however, have a direct relationship to public health, and so we're not recommending that tool at this time. We also considered authorities we have under the MGA to regulate businesses and public places by bylaw. These authorities more directly align with the nature of the restrictions currently imposed by the province and give us an opportunity to go further relying on existing authority. So, for Council's consideration, to impose additional restrictions on public gathering places to help limit the spread of COVID-19, administration has been in the process of drafting a pandemic restrictions bylaw that we would bring forward to a future council meeting. Should council choose to pass this bylaw, it would essentially restrict restaurants, bars, and pubs by closing in-person dining. Takeout, delivery, and curbside pickup could continue. It would identify closure of casinos. It would consider a reduction of capacity to places of worship, and it would consider the closure of fitness facilities and businesses that provide fitness to the public. And so this for us would include the closure of the city's recreation centers. As indicated a few months back when we reported on lessons learned responding to the COVID-19 pandemic, the city charter regulations can be used to modify provincial acts such as the Public Health Act and Emergency Management Act to add additional provisions to allowing our city to exercise public health specific authorities. To do this, the charter regulations would need to be amended by cabinet to modify the Public Health Act to add municipalities as an entity that can issue orders comparable to the Chief Medical Officer of Health, as long as these orders fall under the same authority given to the Chief Medical Officer of Health that can be enforced by our city peace officers. Alternatively, a modification could be made to the Emergency Management Act to add additional authorities to the list of things municipalities can do during a state of local emergency. This could include ordering businesses to close temporarily or further reducing provincial gathering limits. Violations of these orders could not be enforced by peace officers. The Minister of Municipal Affairs would need to modify the MGA requirement for advertising amendments to the charter regulations for 60 days. This is within the Minister's authority when a provincial public health emergency is declared, and it is in the interest of the public. I have reached out to my CAO colleagues in the region, and we've been coordinating with the City of Calgary to advise that we're both considering options for introducing stricter measures on a local basis. Although the most effective way to stop the spread of transmission is for a regional approach implemented at a provincial level, we believe that if steps aren't taken, we need to take these steps. And I think you heard a lot of that this morning with the presentation from the local zone doctors. So that's the quick presentation on that. It kind of gives you an overview of what we're considering for the bylaw, and we're happy to take questions.
And there'll be some that we can get into in public, but just to focus the discussion a little bit about the lay of the land, I'm going to suggest that under Section 16, disclosure harmful to business interests of a third party, 21, disclosure harmful to intergovernmental relations, 24, advice from officials, 25, disclosure harmful to economic and other interests of a public body, and 27, privileged information, that we go in private for the next part of the intergov conversation.
So moved.
Thank you, Councillor Henderson.
Second.
Seconded by Councillor Knack. I'll just test unanimous consent. Any objection to going in private? Not hearing any, then we'll give clerks a moment to ratchet down.
we're online. The peace officers won't be here for another couple minutes if you want to go.
Councillor Paquette, go ahead and make the motion arising from 5.3 and 5.4. And there probably should be a part 7 actually keeping, Madam Clerk?
Thanks.
Madam Clerk, there probably should be a part 7 keeping the discussion in 5.4 in private, subject to those FOIP sections.
Yep, we can add that as a part 7.
All right, but Councillor Paquette, I'll go to you for the motion arising from everything today.
Thank you. Thank you, Mr. Mayor. I move that the December 10th, 2020 Emergency Advisory Committee meeting be canceled. 2, that a special City Council meeting be called for December 10th, 2020 from 1:30 to 5:30 p.m. for the purpose of a COVID update and a discussion on additional pandemic restrictions. 3, that administration bring forward to the December 10th, 2020 special City Council meeting, based on the advice given by the Strategic COVID Pandemic Committee, a pandemic restrictions bylaw that allows for limited gathering in businesses such as restaurants and in casinos, places of worship, etc. 4, and if we can get it to scroll up a little bit, that the mayor, on behalf of City Council, write to mayors in the Edmonton Metro region to inform them of Edmonton's pandemic response bylaw in the context of the learnings from the Strategic COVID Pandemic Committee, and extend a request for a regional approach as much as possible, and an offer of City of Edmonton administrative support in drafting a similar bylaw in their own municipality. 5, that the mayor, on behalf of City Council and in concert with the City of Calgary, write to the provincial government requesting authorities under the City Charter Regulation for exemption from the Public Health Act and/or Emergency Management Act in order to address rising COVID-19 cases in Edmonton and Calgary and reduce the spread of the virus while also enabling businesses to be entitled to the full federal support available. 6, that the mayor advocate for the province to use its authority to protect public health and implement stronger restrictions to bring the virus back under control in the Edmonton Region Health Zone.
Second.
Thank you, Councillor Knack. And there'll be a point 7 that I'm sure will be friendly that just keeps the private briefing under 5.4 in private, subject to the aforementioned 16, 21, 24, 25, and 27 of FOIP. So, Councillor Knack, or pardon me, Councillor Paquette, I'll give you the last word, and if to close.
Thank you, Mr. Mayor. There's not much to say that hasn't already been said.
I want to say one thing before you do, but I'll give you the last word.
Yeah, absolutely.
Okay, so Councillor Nicol, if you could take the chair.
I have the chair.
Clock is ticking in more ways than one here. I just want to underscore that restrictions brought in by the city, even in a regional context with our partners, are suboptimal, and that the best response would be ratcheted up measures from the province under its authority, as I've said many times. However, passage of these sets in motion a plan B, in essence, of working with Calgary and our neighbours to be prepared to enact stronger measures should the need arise. I'm hopeful that the province will take stronger steps. But I would appreciate a strong endorsement from council to continue that advocacy. I've actually already written the letter under 4 and sent it, but it's still good to have the backup of the strategy there in reaching out to our neighbors. And finally, as we've heard today, the situation is dire and urgent measures are needed. The city stands ready to act this week if necessary, but I'm hopeful that the province will use its much stronger and pan-region or pan-Alberta tools to put this virus back in its place. So appreciate council's endorsement of these steps and measures and positions, and I will carry on this advocacy as instructed, provided this passes, of course. Thank you. Take the chair back. And Councillor Paquette, you've got a minute to close.
Thank you, Mr. Mayor. Not much to be said. We are eager to work with the province to solve this issue, to finally put to rest the economic and health anxiety, and return confidence to the people of Edmonton and our region. And we hope that, I hope that these measures will help us get back on the right track, and that we can all move forward together in order to finally put all of this at rest so that we can get on with life with loving and with making a living. Thank you very much.
Thank you. Please vote.
We're waiting for 6 votes, Mr. Mayor.
I'm a yes.
Thank you,
I am
Councillor.
yes too.
Thank you, Councillor Banga. Councillor Katarina.
Yes, for me as well.
Thank you so much, Councillor Essinger.
Yes.
Thank you, Councillor Henderson.
Yes,
Councillor
just came
Walters.
to me, but it's not letting me vote. Yes.
I'm sorry, did I hear Councillor Walters?
Oh, I voted yes.
Thank you so much. We have all the votes.
Display the vote, please. That's carried unanimously. So that, thank you for that, and thank you for staying late. That takes care of 5.3 and 5.4. That's the business for today. We'll pick this discussion up on Thursday at 1:30. Thank you all. We'll see you back in half an hour for the public hearing that's scheduled. So until then, thank you. This meeting's adjourned.